who will be taking some of their exams bago graduate. Ang iba pwede for PGI, ang iba naman for boards. Hindi ko alam. Some of you might be doing residency right now, pero I hope this will be helpful. So for those who are asking for tips, preparing for the boards, start with the basics. Of course, start with God all the time. Without Him, ang hirap mag-retain ng info, hindi mo alam anong aaralin mo. So always ask for God's guidance. That's number 1. Number 2, always start with the basics. So actually, IM is not a basic science. So this is like incorporating the rest of your basic sciences. So start with anatomy, physiology, pathology, biochem, I wouldn't say. Pwedeng doon malapit na sa boards. Kasi mahirap alalahanin yung mga, kasi rote memorization yun. Pharmacology, microbiology, pathology, yun basics. Pag na-master mo yung first 5 to 6 basic sciences, medyo madali na talaga yung iba. As in, kaya mo nang i-survive. So, ngayon, try ko magbigay sa inyo ng mga high-yield concepts sa IM. Ito yung most commonly asked questions na kailangan must know ng lahat. Pag hindi mo alam, okay lang yun. At least time to reflect na kailangan mo malaman siya. May ibang concepts na alam nyo na before, pero kailangan lang i-reinforce. So, gagawin natin yan ngayon. So, habang nakikinig kayo, pwede kayo magsulat. Pwede kayo mag-participate kahit nakamute kayo. O pwede kayong magsagot kasi interactive to. May mga questions dyan sa harap na makikita, no? Try nyong magsagot. Try nyong mag-isip paano ako mag-isip para pagdating sa exam, yun. Ganon din yung technique na i-apply nyo. Huwag kayong mag-depend dun sa choices. Kailangan sa questions pa lang meron kayong iniisip na differentials. Before we start, I just want to share this one. Our inspiration for today, we have to experience God's goodness. Lord, this is our prayer. I do want to know you more. I want the knowledge of you that comes only through experience. Life will have its ups and downs, but as long as I hold on to your goodness, Lord, I know life will be worth living. So this is our goal for today. After a 4-hour lecture, maybe interactive learning activity, board examinees, kasi para to sa mga board examinees before, we'll be able to answer at least 80% with accuracy questions related to cardiology, ID, allergology, endocrinology. May pulmonology pa nga ako. Depende kung hanggang anong topic lang yung kaya natin. Okay? Yun. So, wait lang. I have a question for Abby. Kung may max daw na 100, yung pwedeng makapasok? Someone's asking?
Well, apparently, kuya, send lang din sa akin ni Wendy na parang, tapos pinapashare nga nila sa Facebook pero di ko alam kung paano.
Parang, what's this? Parang i-share yun? Parang Facebook Live? Ganon?
Opo, parang ganon.
Oo.
Ano ba
Kasi
mag-Facebook
hindi makapasok. Paano mag-Facebook Live? Hindi ko alam. Parang may option nata. Ano? Facebook ko? I-share ko?
Pero nire-record ko naman, kuya. Naka-record pa ngayon.
Okay, sige. Yan na lang. Pero pwede namang iba mag-Facebook Live, i-video lang nila yung mismong screen. Hindi.
Sa profile mo, kuya?
Oo. Yung sa screen niya, 'di ba? Pwedeng may mag-video noon tapos i-Facebook Live habang parang gano'n siguro yun.
Okay.
Wait lang. Wait lang ha. Wait. Si RDC set up niya muna. Saglit lang ha. Iyan ko muna yung video ko. Stop ko muna. Okay. Saglit lang, guys. Chill. Kain muna kayo, guys. Wait lang, try ko. Pag hindi, in like less than 2 minutes, I will continue.
Record na lang sa iyo.
Yun na ka.
Ito.
Sige na. Sila na mag-ano.
Kailangan mo. Sabihin mo kailangan.
Nagre-record naman na si Abby. Okay lang. Okay. Balik ko lang yung ano. Wag mo nang i-permit, Abby, yung request ko. Wait, sana yung video ko?
Mag-live na lang ako dito.
Akong video.
Ito-live.
Yun. Ayun.
Abi, ang host daw ata ang magla-live. Sabi ni Dave.
So, kasi tinatry ko, record lang yung kaya kong gawin.
I think
Okay
ako
lang.
na lang mag-Facebook Live.
Okay, sige. Okay, guys. So, let's start off with cardiology. Ayan. So, ito yung pinaka-high-yield na system. So, I guess if there's one system na kailangan nating i-master, ito yun. For the board examinees and sa mga takers ng exams. Kasi, isipin nyo, this is the most common cause of mortality all around the globe. So, most likely yung mga questions mag-rotate dito. Kahit sa anong field. So, kailangan natin yan. Okay? So, first, yan. Syncope. Okay? So, sa questions, we have to know, we have to understand few questions na itatanong mo sa pasyente or sa significant others about the mechanism of syncope. So, you have a better differential of what's going on. So, always ask, anong nangyari prior to the episode of the syncope? And was it sudden or not? Was it progressive? Do you have any pre-syncopal symptoms? Like, was it vomiting, diaphoresis, headache? Yun. So, pag sinabi nilang it was sudden, all of a sudden, yun yung cue nyo sa exam. All of a sudden, nagkaroon ng syncope. Dalawa lang iisipin mo. It's about the heart and the brain. Yun lang. Don't think about vasovagal. Don't think about carotid sinus sensitivity. Don't think situational syncope. Okay? So, always think about cardiac and neurologic. So, cardiac, isipin mo, ano kaya yung mga structural diseases that could cause abrupt syncope without any pre-syncopal symptoms. So, think about, especially kung ang setting is an athlete, biglaan lang nag-collapse, and then no chest pain or palpitations prior, exertional syncope. Yeah, think about hypertrophic obstructive cardiomyopathy, right? Think about aortic stenosis for older people, mitral stenosis maybe for people with a history of rheumatic heart disease, right? Or you also have to think about arrhythmias, any congenital syndromes, prolonged QT syndrome, kung ano mga Bugada syndrome and everything. So, to look for the cue in the exam, abrupt onset of syncope without any symptoms. Heart or brain. Yun lang yan. Okay? Pero pag sinabi doon, nahilo, medyo may diaphoresis or nausea and vomiting prior, ilang minutes pa, parang feeling ko magko-collapse ako. Hindi yan cardiac or neurologic. Okay? Think about vasovagal or neurocardiogenic syncope. Okay? Yan yung most common cause. And then, once you know that it's cardiac or neurologic, of course, hindi mo alam kung anong gagawin mo. Cardiac ba to? Neurologic ba to? Nag-seizure ba to bigla? Or baga nag-subclinical seizure lang? Diba? Na nawalan ng malay. Okay? Kasi may iba, hindi talaga magmamanifest that seizure-like activity. Walang biting of the tongue, walang upward rolling of the eye, walang extremity, movement. So, pwede yun. So, then ask for the mechanism of how they regain consciousness. If it was also sudden, then you can probably say this is most likely cardiac. Okay? So, bigla nawalan ng malay, then bigla din na nagkaroon ng malay, all of a sudden, wala namang ginawa, then most likely it's cardiac. However, if the regaining of consciousness is also gradual, so sudden onset of syncope, and then gradual regaining of consciousness, think about neurologic symptoms. Especially pag merong post-syncopal confusion. Okay? Pag halimbawa, hindi ko pa alam saan ako, yun, groggy pa. Most of the time, may nagkaroon ng seizure yan. Although, kailangan mo i-confirm yan with an EEG. Pero by history pa lang, you have an inkling that this is neurologic. Okay? So think about cardiac and neurologic if it's sudden onset, and then think about cardiac if the regaining of consciousness is sudden, and neurologic if it's gradual. Okay? And then, of course, you do your cardiac exam. If ever you are thinking of arrhythmias, if ever you're thinking of HCOM, then I will teach you later some of the best cues to lead you to the diagnosis. Okay? And most of the time, kailangan dyan may EEG para makita mo kung may arrhythmias, kailangan mag-echo ka to see if may septum abnormalities, meron ka bang tamponade, meron kang kung ano-anong valvular diseases. Okay? Sometimes you always have to rule out any ischemia. So, andun papasok si troponin, andun papasok si KMB, yeah? Diba? And yeah, okay? So, yun yung mga basic thoughts natin. And also, other differential for gradual regaining of consciousness, think about toxic metabolic. Ang dami dyan. Ang daming possible causes dyan. Pwedeng hypoglycemia lang. Okay? Pwedeng drug intoxication, or pwedeng alcohol intoxication, okay? Or pwedeng hypoxemia, or pwedeng COPD siya, nag-hypercapnia, hypoxia, or anemia severe. Okay? So, yun. Pero 90%, okay, remember this one, of mortality from syncope is from cardiac cause. Kaya kailangan mong i-rule out to. Okay? That's why yun yung first topic ko. Kasi kailangan mong malaman na rule out the possible cardiac causes for sudden onset of syncope. I hope that's clear. That's just for syncope. Okay? Yun lang kailangan mong isipin once you answer questions about loss of consciousness. This one. I hope you would read with me. This one, a 48-year-old woman. Okay? Sa demographics pa lang, babae na 48 years old, do you think more likely magkakaroon to ng cardiac cause? Let's see. Comes to the office, not the hospital. So always think about the setting. Okay? Pumunta lang sa office mo, baka hindi ganun ka-severe. Right? Kasi kung feeling niya mamamatay siya, hindi pupunta yan sa emergency department. Okay? So first phrases pa lang. Okay? Few sentences. Not too serious. Maybe. Okay? And the chief complaint is chest pain that has been occurring over the last several weeks. Isipin mo, ang tagal-tagal na. Less likely ACS to. Less likely MI to. Right? The pain is not reliably related to exertion. Okay? So hindi exertional and pain. And she is comfortable now. The location of the pain is retrosternal. Okay, mukhang cardiac, maybe. By location, the pain is sometimes associated with nausea. Yun. And there is no shortness of breath, and the pain does not radiate beyond the chest. So localized siya. And she has no past medical history. Guys, the easiest question in the board exam is, what is the most likely diagnosis? Pag na-miss mo yan, good luck sa'yo. Okay? Pinakamahirap yung mga, what is the next management? What is the most appropriate test? What is the most appropriate management? Tapos magkapare-pareho sila. So pag may nakita kang question, what is the most likely diagnosis? Please lang, pag-pray mo, wag ka na magkamali. Okay? That's the easiest question. Okay? So what do you think? Tingnan natin isa-isa. GERD, unstable angina, pericarditis, pneumothorax, twins metal angina. Yan, magsagot lang kayo dyan sa phone nyo or sa laptop nyo. Alam ko makukuha nyo to. Okay. Review lang natin yung definition ng angina. Okay. So we have typical angina, atypical angina, and non-anginal pain. Okay. So for typical angina, kailangan it will meet 3 requirements. The first one, it is the location should be substernal or retrosternal, which our patient has. So meron siyang 1 criterion. Pangalawa, it should be exertional. Okay. And pangatlo, it should be relieved by rest. So, kailangan yung tatlong component na yun andun for you to say that this is a typical angina. Okay? Pag dalawa lang out of 3, that is atypical angina. For example, sabihin natin retrosternal, tapos sasabihin niya exertional, pero hindi consistently relieved by rest. So, that's 2 out of 3 criteria, right? That's atypical angina. If it's only meeting 1 criterion out of 3 that I have just said, then that is non-anginal pain. So sa atin dito, sa question natin, tingnan natin kung anong klaseng angina to. The location is retrosternal, that's 1 criterion. It's not reliably related to exertion, -1. Hindi sinabing relieved by rest. Kasi ngayon, she is even comfortable now and wala siyang ginagawa. Diba? So likely this is non-anginal. So by the definition pa lang, you can easily rule out unstable angina, letter B and letter E, right? And you are only left with 3 choices to choose from: GERD, pericarditis, or pneumothorax. Sino magsasagot ng pneumothorax? Hindi ka pupunta ng clinic with a pneumothorax. Pericarditis most likely is positional. Okay? Ang makikita mo dyan, aggravated by relieved by sitting forward. Yeah, di ba? Aggravated by lying flat. Yun yung makikita mong question cue. Okay. So I hope you got the answer to this question. Meron kang clue, nausea. Pero minsan nausea can be non-specific and can be related to ACS as well. That's typical equivalent of angina. But by the looks of it, 48-year-old woman, and you know that the female in the reproductive age virtually doesn't have any ACS, okay, because of the protective effect of the hormone estrogen. So the correct answer is GERD. I hope you got it correctly. Tip: menstruating women, as what I have said, virtually never have MI. Okay, 50 to 60% protective effect of menstruation and naturally occurring estrogen have worn off kapag nasa ano ka na. I mean, pag nag-menopause ka, 55 to 60%. 55 to 60 years old, yun, nawawala na yung protective effect ng estrogen mo. And most of the time, equal na yung risk ng MI between men and postmenopausal women. Okay? But virtually, yeah. Another tip, but overall, more women will eventually die of heart disease than men. Bakit? Yun, kasi yung mga babae, mga martir, right? They can endure pain. Tapos okay lang yun. Hindi naman kailangan magpa-hospital. Kaya lang. Hindi kaya ng mga lalaki, konting sakit lang. Para na yun agad. Hindi kailangan magpa-hospital. So it's more related on the behavior, seeking behavior of our women. Especially about the pain. Mas mataas yung kanilang tolerance to pain. Kaya if you can see the statistics, more women are dying from MI if ever they have. Okay? How about this one? So which of the following is most likely to benefit a patient's risk of coronary disease? So it's knowledge about prevention, right? This is very important in exam. So I hope you will get this right as well. Medyo madali lang yan. Administration of estrogen, replacement at the time of menopause, stopping tamoxifen, stopping aromatase inhibitors, regular exercise, and relaxation methods such as meditation. Medyo obvious yan. So, ayun. So, as what I have said, estrogen can be protective. However, can benefit, most likely benefit. Paano kung hindi naman sinabing at the time of menopause? Okay? Paano pag hindi sila menopause? Maging true pa ba kayo yung statement? How about tamoxifen? This is SERM, right? Selective estrogen regulator. Most likely, binibigay yan sa mga pasyenteng may breast cancer, right? They are antagonists to the breast tissue, but they are agonists to your endometrial tissues. That's why you're at risk for endometrial hyperplasia and even cancer development. Okay? Pero wala siyang related to coronary disease benefit. Aromatase inhibitors, mga lastrozole mo, most likely given to cancer patients post-menopausal. Okay? And yan, isa lang dyan yung preventive, guys. Regular exercise. Okay? So, yan. Just to review you on one of options you have if ever you have a patient with breast and uterine cancer, both. You cannot give tamoxifen, right? Because tamoxifen can cause endometrial hyperplasia. You have a better option to this. You have the medication raloxifene. Okay, they're antagonists to the breast and also antagonists to the uterine tissues. So protective siya for both. And plus, agonist siya to the bone. So it can also help with osteoporosis. So kung meron kang setting like a patient with breast and uterine cancer and osteoporosis, yun. Answer, raloxifene, not tamoxifen. Okay? So estrogen may improve LDL but doesn't help in CAD. Remember that one. And remember this one, the most clearly agreed upon risk factors for CAD, diabetes, that's an anginal equivalent or CAD equivalent, tobacco smoking, hypertension, alam niyo ito lahat, modifiable risk factors. Pero kailangan niyong malaman itong mga ages na to, kaya na-highlight ko siya. So, family history of premature CAD. Remember the age. Kung meron kang tatay or brother nagkaroon ng MI earlier than 55 years old, at risk ka. For female, 65 naman. Half. Pero pag age, just subtract 10. So just memorize one set of number. And then for the age, 55, above 55 is at risk kung babae. 45 kung lalaki. So sa first question natin kanina, that was, I guess, 48-year-old woman. Kaya hindi siya at risk, right? Kasi ang at risk lang is about 55, that's menopausal age. Minus 10 ka lang para sa lalaki. Then for the premature CAD, lalaki is less than 55, babae is less than 65. So kung makikita nyo, yung lalaki mas mababa yung threshold. Okay? Then the female, because that's what I have said, from the protective effect of estrogen. Remember this ones, these risk factors. Kasi nung nag-board exam ako, tinanong yan paulit-ulit. Pero iba yung question, hindi, what are the risk factors? Hindi, what is the most likely, what is the risk factor associated with the highest risk? What is the most common risk factor? Yung mga ganun. Yung feeling mo, alam ko sila lahat related, pero hindi ko alam sino which among them has the most benefit kapag in-stop ko, kapag ni-resolve ko. Yan, mamaya, di-discuss natin yan. But remember this, guys, okay? In your practice as well, those who will be going into residency, those who will be practicing as physicians, yun. Kailangan natin malaman itong mga risk factors. Okay? This one. What is the worst risk factor for CAD? Wait lang. Ito ba yung aking inedit? Bakit parang hindi ito na-change? Give me a second. Kaya pala. Okay. So what do you think is the worst risk factor? Diabetes mellitus, because it is the what's this? CAD equivalent. But the most common is actually hypertension. Okay? Pero ngayon, according to the 2017 American College of Cardiology, pag ginanong kayo, the risk factor that has the highest, that poses the highest risk for CAD, hindi na diabetes mellitus. Okay? Alam mo yung sagot dito? It's hyperlipidemia. Okay, so prior to the change, the newest guideline, so pag dinanong kayo guys about the risk factor associated with the highest risk, or the factor associated with the highest risk of CAD, you have to answer hyperlipidemia. Okay? Not diabetes mellitus. Sorry, hindi ko na-update yung aking slides. Okay, family history. Only CAD in first-degree relatives. Hindi po kasama yung grandparents in the history. Hindi kasama si aunt. First-degree relatives pertain to your siblings and parents. Okay? And only premature CAD is at risk for the patient as well. I hope you still remember the age. For men, it's 55, younger than 55. And for women, it's younger than 65. Remember, only first degree, okay? First degree includes your siblings and parents. This one, most common wrong question and risk factor questions. Most common wrong answer, sorry. Mistaking CAD in elderly relatives. Okay? Grandparents, even if they're patients' parents. Age is presented outside the risk factor guidelines. So think about the ages, that's what I have said. Hindi porket matanda. Okay? Or hindi porket grandparents mo kasama mo siya sa risk factor. So remember the age, 55 and 65 for premature CAD. And age risk factor is just minus 10, 45 and 55. And first degree only. This one is an easy question. Okay? Which of the following is the most dangerous to a patient in terms of risk for CAD? Dali lang yan. Alam na natin, di ba, that hyperlipidemia is the factor associated with the highest risk of CAD or CVD. Elevated triglycerides, total cholesterol, decreased HDL, elevated LDL, or obesity. Okay? Rule out obesity. That's why, apat na lang. So among these 4, well, you know, the bad cholesterol, ito yung goal natin. Actually, previously, goal is to have this level of LDL, but right now it was changed. So I'm gonna tell you paano minodify yan ngayon. So always don't look about triglycerides. Don't look for total cholesterol. Don't look for HDL. Look for LDL. Okay, that is the most. That is one component of a lipid profile that is related to the risk of highest risk of CAD. Kaya di ba sa mga statins, meron tayong goal like 30 to 50% reduction after ilang months. Ganun. Okay, so think about LDL when it comes to modifying risk factor for CAD as far as hyperlipidemia is concerned. Again, I repeat, the risk factor associated with the highest risk for CAD now is hyperlipidemia. Okay? Try nyo sagutan yung question na yan. Medyo easy. Postmenopausal woman, you are sure that this patient is at risk for ACS, if ever this is an ACS question, develops chest pain immediately on hearing the news on her son's death in a war. So triggered by stress, pwede, right? She develops acute chest pain, dyspnea, and ST segment elevation and leads V2 to V4. Ako, mukhang STEMI na STEMI. You have a classic chest pain. Hindi binanggit kung relieved by rest, hindi binanggit kung retrosternal. And but you are sure that the ST segment is elevated. So baka MI, madaming ibang factors that could cause ST segment elevation. It's in the anterior chest wall. Elevated levels of troponin confirm an acute MI. So meron kang troponin leak, meron kang ST elevation, meron kang chest pain. Mukhang STEMI talaga, right? But the coronary angiography revealed normal findings, malinis, clean coronaries, and also the absence of vasospasm on provocative testing. So maybe gusto nilang i-rule out yung Prince-Metal angina because, you know, in Prince-Metal angina, you have also like a presentation of STEMI with clean coronaries, pero meron kang vasospasm on provocative testing. So dito sinasabi nila, hindi yan Prince-Metal kasi wala kang vasospasm, and then normal din yung coronaries mo. Now, the clue is here in the echo. It reveals apical left ventricular ballooning. Yeah. Ano yung apical ballooning syndrome natin? What is the presumed mechanism of this disorder? Some of you know about the diagnosis. Iba hindi. Tingnan natin. So, ang ating marurule out dito, wala kang obstructive lesion. So, malamang hindi to emboli to the coronary arteries, right? Plaque rupture is the pathophysiology for your MI. So, wala ka ng C and D. Tatlo na lang. Absence of estrogen. What do you think is our presumed mechanism for this disorder? Magdalawang isip ako. Related activation could be related to the plaque rupture as well. That could be obstructive. So C, D, and E actually is related to obstructive lesion in coronaries. So you are left with the 2. So kung ako manghuhula lang, mukhang A and B lang. So 50-50 tayo. Okay? But you know that this is a massive catecholamine discharge mechanism for your Takotsubo syndrome, right? The heart-broken syndrome. The broken heart syndrome. Apical ballooning syndrome, that's the other term for that. It was coined in Japan in 1990, right? It's because of, response to stress. You have catecholamine discharges, increasing your demand from the heart, and then, binding the receptors in the heart, causing all of those exhaustion. So, pwede kang magkaroon ng ischemia because of that. And you have to rule out pheochromocytoma in that case before you can diagnose Takotsubo syndrome. Be sure that the coronaries are clean bago mo masabing Takotsubo cardiomyopathy siya. And usually, yun, may ballooning. Specific regional territory lang yung kanilang affected. Pero there are some instances na, ayun, meron siyang affectation ng iba. Pero yung clue nyo for those who are taking the board exam, look for this: ballooning, clean coronaries, and a picture of STEMI. Okay? And usually the management is not revascularization. Wala ka namang lesion dyan. And also, ayan, most of the time it's pharmacologic. So give something to block catecholamines. So think about beta blockers. Okay? And sometimes ACE inhibitors as well can help. Okay. Correcting which of the following risk factors for CAD will result in most immediate benefit? See, sinabi ko sa inyo kanina, di ba? There are a lot of questions about risk factors, especially with preventive medicine. Yan, titingnan mo, halos sila lahat beneficial. If I remedy DM, if I have a better glucose control, pwede magkaroon ng benefit. Tobacco smoking, hypertension, hyperlipidemia, di ba? If you are confronted with this question, malilito ka. But according to studies, within a year of stopping, actually the risk of CAD decreases by 50% once you stop smoking. Okay? And within 2 years, even now, like 5 years, pwede ka nang, yung risk mo is almost like the same with a non-smoker. So yun yung one of the motivation you can give to your patients. Na yun, after 5 years to 10 years of smoking, the risk of having CAD is equal to those who have never smoked. Okay? So yun. So I hope we have learned a lot about risk factors already. Ano yung pinaka-highest risk? Dyslipidemia, the most common, hypertension. Ano yung risk factor will result in most immediate benefit? Kung ma-remedy mo, that's tobacco smoking. Okay? So those are the main things for your risk factor. Remember ischemic pain? We have already talked about the 3 criteria for typical angina. It should not be tender. Okay? If it's reproducible, pag pinoint mo, oh, can you show me where the pain is? And then they point to somewhere. And then once you put it, once you touch or palpate, and then they grimace in pain, that's tenderness. That's not likely ischemic. Could be costochondritis. Could be Tietze syndrome. Yeah. It's not positional, as what I have said. Most likely, kung positional, that's pericarditis. And it's not pleuritic. Okay, kailan ba mas masakit? Once I inhale, yeah, I feel like the pain is worse. Yeah, that's pleuritic chest pain. Likely, like related to pneumonitis, or pwedeng related to pneumothorax. Okay, pwedeng related to some like tamponade can give pleuritic chest pain or pneumonia. Okay, so not ischemic pain. And the most common cause of chest pain that is not ischemic in nature, yun yung first question natin kanina, always rule out gastrointestinal disorder. Okay? Yung GERD, GERD can even present with like asthma symptoms or chest pain symptoms. Okay? If it's not ischemic in nature, always think about your GI system. Yun, tingnan natin dito. So we can answer with me. Okay? Answer as most likely diagnosis or when the question is about most accurate test. Okay? Pag sinabing chest wall tenderness a question. Okay? Think about costochondritis. Right? Pag wala yan, Tietze syndrome. Search na lang T-I-T-Z-E. What is the most accurate test? Wala. Just have to do physical exam. Gawin mo lang yung part mo. How about this one? Radiation to back. Yun. Classic tearing and ripping pain. And then when you did the blood pressure, unequal between arms. Okay? Minsan, nagmamurmur ba yan hanggang sa likod? Ganun. Okay? That is a classic for your aortic. So, that is classic for aortic dissection. And the most accurate test, TE can confirm that. Or transesophageal. Pag unstable yung pasyente, mag-MRA ka na lang or CT angiography. Okay, para makita mo. Pero initial test, pwede ka mag-chest x-ray, makita mo, you have a widened mediastinum. That's a clue that probably this is an aortic dissection. Okay? And we will review later some of the few tips once you answer questions for aortic dissection. What do you do? If it's type A or type B, Stanford, anong kailangan mo gawin? Surgical versus medical therapy. We will talk about it later. And also some of the screening for aneurysm and dissection. How about pain worse with lying flat? This is what I've told you already, and better with sitting up and young. Okay, so this is a positional type of chest pain. That is your pericarditis. And what is your EKG change? So kung titingnan mo, most likely ST elevation everywhere. But what's this characteristic of EKG elevation is most likely concave than convex. I hope I have a. Let me see if I have a sample of that. Wala dito. Wait, give me a second. Para lang makita nyo na yung pericarditis is ST segment elevation pa rin. However, the morphology of the ST segment elevation is not convex. Usually, pag sinabi mong convex, yung parang chair pattern. Pero sa pericarditis, usually concave siya. Let me see kung meron ako ditong pericarditis picture para lang makita nyo. And most of the time, we have a most specific sign na hinahanap mo, which is, pag nakita mo yun, most assurable. Ayan. So, give me a second. I'll just show this one and then, nawala dito. So, i-fix lang namin muna yung FB Live. Wait lang. I will just give you some time for break. Saglit lang, okay? I will just need... Saglit lang guys ha, fix ko lang yung FB Live. Ayun. So, yeah, this is a classic. Do you see my screen for an EKG?
Yes, po.
Yes,
Okay.
yes, kuya.
Okay, so if you can see this one, ST segment elevation, look at this. So this is concave in shape. And the most specific that I want you to look at is this PR segment elevation. Most of the PR here are actually depressed. So look at the PR, that's the segment after the P wave, before the QRS. So in all the leads, you can see it's depressed, okay, except for leads in AVR. Look at AVR, that's very specific for PR segment elevation. Okay, so once you see that, most likely it's pericarditis. All right, don't confuse this with a classic STEMI. Okay, so let's see, balik ako doon sa slide natin. So, alam na natin yan. Let's see. Okay, so yun, nasagot na natin. And epigastric discomfort, pain better with eating. So if it's related to food intake, think about ulcer, peptic ulcer disease. It can be duodenal or gastric. So if it's relieved with eating, that's duodenal. The other way around, yung gastric, right? Kasi yung gastric ulcer, the ulceration is in the gastric area. Once the food induces acid secretion, so it can interact with an ulcer with an exposed mucosa. So you have aggravation of the pain once you eat in gastric ulcer compared to duodenal ulcer. And diagnostic test depends kung endoscopy or pwedeng, if you're thinking about H. pylori, you can do urea breath testing. Never do antibody testing. Okay, remember that. You can do stool testing for H. pylori, but not antibody. Okay, and you have to rule out. You have to also ensure eradication after treatment with a triple therapy of antibiotics. How about if you have a question about bad taste, and then you have a cough, and you have in the question hoarseness of the voice with a chest pain? This is classic for your gastroesophageal reflux disease, right? So look for those clues in the exam, and then the most accurate test. Actually, wala kang test. Just try to do give PPI for 2 weeks, and if the patient responds, then most likely it's GERD, right? How about if you have chest pain? A patient with chest pain, cough, at the same time sputum production, and sometimes hemoptysis. It could be pneumonia. That's a general term for parenchymal inflammation, right? Pwedeng viral, pwedeng mycobacterial, pwedeng bacterial lang. Okay? And most accurate test, chest x-ray for pneumonia, like bacterial pneumonia, pwede. Right? Pero kung atypical pneumonia, you can do Legionella testing, diba? Legionella antigen urine. For TB, that's a different story. Okay? How about if you have chest pain, sudden onset of shortness of breath, and then tachycardic and hypoxic in the setting of sabihin nila, prolonged immobilization or travel history more than 6 hours, or merong malignancy history, or sobrang taba, or hormonal, there's history of hormone use, think about embolism, right? And answer the most accurate test, spiral CT. Right now, chest CT is the most accurate test unless the patient is allergic to contrast. You can do a VQ scan. Also, if the patient is pregnant or mga bata, or you are thinking of a pulmonary hypertension state, group 4, like the chronic thromboembolic disease, CTEPH, or chronic thromboembolic pulmonary hypertension, VQ scan is the most accurate test. But most of the time, if it's pulmonary embolism, think about chest CT with contrast, CT angio, okay? Unless sinabi ko na kung may history of allergy to contrast. How about if the chest pain is sharp and pleuritic, and you have tracheal deviation? Yun, nakikita mo yun sa chest x-ray, or even dun sa stem ng question. And sabihin natin, COPD patient, bigla na lang chest pain, or even a young smoker. So think about pneumothorax, right? Pwedeng spontaneous pneumothorax, pwedeng tension pneumothorax, okay? And tracheal deviation opposite to the side of the pneumothorax, right? Because it will push the mediastinum to the opposite side. Once it sucks the mediastinum to the same side, then it's likely atelectasis. Remember that one. But if it's fluid, if it's air, then it should compress the mediastinum to the opposite side. And most accurate test, actually initial test, you can do a chest x-ray. You can see lack of vascular markings in that area, and you can see a pleural line to separate the air from the pleural space, and tracheal deviation. Those are the main things. And then once you auscultate, you don't have any breath sounds in that area. So those are the main clues for pneumothorax. Okay, another tip for chest pain is what I have said in the office. Sometimes, like, you don't really have to test for it, troponins elevation. Kasi nga sa sinabi ko na, they come to the clinic not with an ACS pain. Kasi kung meron silang acute coronary syndrome pain, nako, hindi nila kaya. Okay, they have to go to the emergency department. They're diaphoretic, they feel like impending doom, they're dying, so they have to go to the emergency department. And most of the time, not all the time, if it's in the clinic, you don't have to do any enzymes, unless in very few cases. Okay. So in the emergency department, the first thing you do is, especially if you are suspecting for an acute coronary syndrome, for like minutes to hours, you can get the enzymes after an EKG is performed. Okay, so tingnan mo muna EKG if it's ST segment elevation or depression or wala. And then after that, if you're still suspicious, just get the enzymes. But most of the time, you have to have a good differential in your head before you do these things. Right? And remember this one. Stress testing is the answer when the etiology of the chest pain is uncertain. You are not sure. And the EKG is not diagnostic. Hindi ka sure if this is ACS, but still you have a strong suspicion. Bakit ang tagal-tagal na, like weeks to, pero 70 years old, mataas yung history and risk factors, mukhang unstable or stable angina. And then EKG, hindi naman ganun ka-diagnostic. Mukhang may block, pero hindi ako sure. What you do? Do a stress test. That's the scenario na kailangan mag-stress testing. Okay? It could be exercise stress testing, EKG. It could be a stress pharmacologic stress testing. It could be an echo stress testing. We will discuss in a few minutes. Paano mo i-choose yung best stress test for certain patients. Kasi iba-iba yung indication nila. Okay? So if you are not sure about if it's ACS or not, CAD or not, do stress testing. Unless it's GERD related. But even then, kahit nga, minsan, kahit feeling mo GERD, hindi nagre-respond to PPI, may chest pain pa rin. Kailangan ko ka rin i-rule out yung ACS in this case. Okay? Now remember, ACS, meron kang unstable angina, and STEMI. Okay? Stable angina is not part of the acute coronary syndrome. Remember that. And once you do stress testing, you have a maximum target heart rate para masabi mo that the test was adequate. You have to have 220 minus the age of the patient. That's your maximum heart rate. So like in my case, if I'm 30 years old, 220, I have 190. So dapat makuha ko yung 190 heart rate per minute bago ko masabi that the EKG change na nakikita nyo is adequate or that the test is adequate. So an exercise means that the patient can get his or her heart rate up above 85% of maximum. Okay? So 85% of 190, pwede mo i-compute yan. Okay? That's your maximum na pwedeng masabi mo the test was adequate. Okay? So there are two factors na kailangan mo malaman in exercise tolerance testing. Okay? Dalawa lang ilagay mo sa brain. If you can read the EKG, or the patient can exercise. Those are the two main things. Can I read the EKG baseline? If I can read the EKG, like this is a normal sinus rhythm, then you can do an exercise testing using an EKG. Pag hindi, then you have to think of other modalities. Okay? And then the next question you have, can the patient exercise? Because if the patient cannot exercise, huwag ka na mag-exercise testing. Okay? You can give medication that could mimic an exercise. Okay? You can give medications that's pharmacologic testing. Okay? If the patient cannot exercise. So first thing, ask yourself, is the EKG readable? Is it normal? If not, there are certain EKGs that would tell you, ops, don't use EKG in the stress testing. Wala, maguguluhan ka lang. Okay? And then if the patient cannot exercise, you can just give medication. Okay. First scenario, what if you cannot read EKG? It doesn't necessarily mean hindi ka marunong magbasa ng EKG. Pero what if yung baseline EKG mo looks like this? Okay? Ano sa tingin nyo to, guys? V1, very deep S, very, very small R. And then look at the V5 and V6. You have a R, monomorphic R wave. And you have a deep S. Minsan matangkad din yung, and then you have a almost like a wide QRS. Okay? So this is a left bundle branch block. So if meron kang LBBB, most likely huwag ka nang mag EKG stress testing. Okay? Kasi baseline pa lang, hindi mo na alam kung ST segment elevation na ba to, right? Okay. Paano pag meron kang ganitong EKG? Baseline sa pasyente. I hope you still remember this one. Look at the PR. They are shortened. And you have a delta wave right there. Okay, it rings a bell. Okay, so those are classic for your Wolff-Parkinson-White syndrome, right? Pre-excitation, meaning that the conduction is not going through the normal pathway. Sinasabi natin dun sa SA node, going to the AV node, then to the bundle of his, and then down to the ventricles. Dapat wala kang ganyan makikita. Usually, sobrang excited nila. Napaka-short na ng PR nila. Okay? And then, sa sobrang excited, makikita mo na yung parang may extra, advanced, wave, bago hindi siya sharp. Ganun ka-sharp yung QRS mo. That's a delta wave right there. And that's classic PR, shortened PR, and then a delta wave. That's classic for your pre-excitation pathways. It means, hindi dumadaan dun sa normal conduction ang conduction. I mean, hindi dumadaan sa normal conduction pathway. Maybe may ibang accessory pathway na dinadaanan. That's a Wolff-Parkinson-White syndrome kapag may symptoms. Without symptoms, there's a Wolff-Parkinson-White pattern. Okay? Pero pag may symptoms siya at makita mo yung ganyan, delta wave, shortened PR, and that's a WPW syndrome. Okay? And pag may ganyan yung baseline ng pasyente mo, ay, huwag ka nang mag-EKG stress testing. Maguguluhan ka lang. What if ganyan? Clue mo dyan, meron ka nakikitang, bakit may mga spikes? Yan, may mga spikes ka bago yung QRS. So ito, ventricular pace to. May pacemaker yung pasyente mo dito. Look at that. You have a wide QRS, right? So, guys, remember, kapag wide yung QRS, isipin mo, ay, hindi dumadaan yung conduction dun sa normal. Kasi usually, kapag dumadaan yan sa AV node, bundle of his, bundle branches, ventricular pathway, dapat narrow lang yan, normal. Pag nag-widen yan, baka dumadaan sa ibang pathway. Baka may pacemaker na gumagana, okay? So, this is a ventricular paced complexes. So, pag ganyan, huwag ka nang gumamit ng EKG sa stress testing. Maguguluhan ka lang din, okay? Sa result. How about that one? Look at this. Look at this ST. These are depressed, right? Look at the classic ST depression in V2, in V3, in V4, V5. Ayan. So, ST depression at baseline, pag nakita mo yan sila, huwag ka nang gumamit ng EKG dun sa stress testing mo. Okay? So, what if you cannot read the EKG, not because you do not know how to read, but because the EKG at baseline is questionable or meron na mga underlying abnormalities, so huwag ka nang gumamit ng EKG. You can use two options. You can do echocardiography, but this is assuming that the patient can still exercise. So pwede kang mag-echocardiography, testing, stress testing. So habang nag-exercise siya, hindi EKG yung tinitingnan mo, but the echocardiographic changes. Baka merong mga wall motion abnormalities or WMA. Diba? So baka sa isang part ng heart, hindi nagpa-perfuse. For example, sabihin natin, inferior wall ng heart, hindi nagpa-perfuse. Likely the right coronary artery is affected, right? Because the RCA actually supplies most of the inferior wall of the heart. Or pwedeng sabihin natin, ang anterior wall ng heart hindi masyadong parang may hypokinetic changes, hindi masyadong nagko-contract. So isipin mo, baka what's this? Baka yung artery from the left main coronary, like descending artery, yun yung affected. Okay? So echo, kapag hindi ka makapagbasa ng EKG, or pwedeng nuclear isotope. Ito yung mga nuclear testing, thallium or sestamibi. So kapag ang isang portion of the heart is not receiving enough oxygen, pag ischemic, most likely they have a less uptake of this isotope. Kapag normal, they have a normal uptake. Okay? Makikita mo yan kapag fixed. Kapag fixed yung lesion, regardless of whether the patient exercises or at rest, makikita mo yung uptake is just the same. That's an infarct. Pero pag nakita mo, oh, kapag nag-rest, nawala. Okay yung uptake, normal. Kapag nag-exertion, the uptake is low, then that's probably ischemia. So, pwede mo pang ma-salvage yun. Right? So, those are the main things. If di mo magamit yung EKG, but the patient can still exercise, do nuclear stress testing or echo stress testing. Okay? So, yun yung dalawa. Between the two, sana hindi sila magbigay ng option na may dalawa. Okay? Kasi of course, merong advantage ng isa over the other. Kapag meron kang LBBB, usually, left bundle branch block, ayaw mo ng echo. Usually. Okay? Yun lang naman yung advantage ng isotope. Pag may left bundle branch block, better go with the nuclear stress testing. Okay? Remember, the ischemia, as what I've said, gives reversible motion wall abnormalities or thallium uptake between rest and exercise. But the infarction is irreversible. If it is fixed, whether you are at rest or whether you're doing exertion, nakita mo yung wall motion abnormalities andun lagi. That's a sign of infarction. Okay? And it's reversible, this is a sign of ischemia. Now, the next question is, what if the patient cannot exercise? Okay. So, halimbawa, you can read the EKG. Okay, normal ang baseline EKG. Kaya kong gamitin to. But when you ask, like, how many blocks can you walk? Can you tolerate walking 1 flight of stairs? Di na pasyente, wala, hindi ko kaya. Hinihingal ako, sumasakit yung aking chest. So, do chemical stress testing, or other term is pharmacologic stress testing. Meaning, you give a medication that would mimic an exercise. So, dobutamine, you know, that's a beta-1 receptor agonist. So it will increase the heart rate. It kind of mimics your exercise. And then while you give the dobutamine, you also do an echocardiography. If the patient's EKG is at baseline pangit, so echo ang gagamitin mo, and then plus the dobu. Or other institution would use dipyridamole or adenosine. Remember that dipyridamole is antiplatelet medication, but at higher doses, they are vasodilatory. So the clue is, the pathophysiology may be like vasodilation, you have low blood pressure, then you have a reflex tachycardia, so tachycardia can mimic exercise. Same is true with adenosine, okay? So it can also be vasodilatory via your GI system, and you have decreased cramp, and then you have decreased, you can have relaxation. Increased cramp via GS, and then you have relaxation of the smooth vascular muscles, and you have a reflex tachycardia in that case, okay? And that can mimic your exercise by increasing your oxygen demand, right? Okay, so those are the main two things. So, are you able to read the EKG? If yes, okay, I can use the EKG in the stress testing. Is your patient able to do has the capacity to do exercise? Then you do the normal exercise stress testing. But if not, hindi makapag-exercise, use medications. Hindi ka makapagbasa ng EKG, use echo versus nuclear isotope. Okay? And once meron ka makitang defects doon, then eventually do a coronary angiography. So pag halimbawa, abnormal nuclear stress testing nakita mo, abnormal echo with wall motion abnormalities. Okay? And then you eventually end up with coronary angiography. Okay? That's your left heart catheterization, coronary angiography. How about answering this question? Try natin. A man with atypical chest pain, it means maybe 2 out of 3 of the criteria that I have said. Retrosternal, exertional, and relieved by rest. Those are the 3. So, ito, atypical, baka dalawa lang. Okay, 2 out of 3. A man with atypical chest pain is found to have normal nuclear isotope uptake in his myocardium at rest. On exercise, there is decreased uptake in the inferior wall. Okay, so mukhang hindi to infarct, right? Kasi reversible at rest, normal, pero on exertion, there is problem with the uptake in the inferior wall. Question, anong artery ang nagsusupply ng inferior wall? As what I have said, this is right coronary artery. So most likely right ventricular infarct, right? 2 hours after exercise, the uptake of nuclear isotope returns to normal. So it looks like it's reversible. What is the right thing to do after that? Do you do angiography? Do you do bypass surgery? Do you do PCI? Dobu echocardiography or nothing? It is an artifact. It's never an artifact. It's consistent, right? at rest and 2 hours after exercise, you have the same findings from the normal uptake of nuclear isotope. And on exertion, you have a decreased uptake. So letter E is wrong. Between B and C, actually, yung dalawang yan, those are interventional in nature. And then what is the right thing to do after you see this one? You have to the anatomy. You can just do bypass surgery without knowing which artery is it. You know that it's like RCA because of the inferior wall, but before doing any intervention, you have to exactly know where it is, right? Kasi hindi po pwedeng pachamba-chamba ka lang, RCA ako, LC, left main coronary, or descending, left anterior descending. So hindi po pwede yun. So there are always criteria for bypass surgery versus PCI, right? We will discuss later. Paano malalaman naman kung bypass ka, paano kung angioplasty lang, okay? W echo, I don't think I need to do this one because you already have a nuclear stress testing, right? So echo will not give you any advantage or any additional information about the patient's case. And most likely this patient has left bundle branch block, I believe. Bakit nila ginawa yung nuclear isotope versus the butanol? So in this case, since you want to know the anatomy, okay, the description of a nuclear stress testing is reversible ischemia. It needs angiography. And remember that you cannot determine what type of revascularization unless you know the anatomy. If it's irreversible, like fixed, then, well, it's too late to revascularize an infarct tissue. But in this case, it's still reversible, so pwede ka pang, may magagawa ka pa. So do a diagnostic testing to define the anatomy, where is the lesion, and then from there on, decide. Kailangan ka ba mag-bypass or PCI? It depends, okay? Oops. Your screen is paused. Okay. What is the most accurate method for detecting CAD? Most accurate. Yung nakikita mo talaga. Okay, that's your coronary angiography. Pag wala yan, other term is heart catheterization. Most likely, it's left heart catheterization. Kasi doon ka dumadaan sa aorta. Pag right heart cath, dumadaan ka sa inferior vena cava. Kasi papasok ka sa right atrium. Okay? Pero pag gusto mo, doon mismo ka papasok sa coronary arteries, dito ka magdadaan sa left side. Okay? Pero that's the standard term, coronary angiography. Okay? What if you have a 1 or 2 vessel disease? So sabihin natin, meron kang RCA, meron kang left main, or sabihin natin right posterior interventricular branch. Kung isa lang or dalawang vessel, you can do stent placement. Okay, that's your angioplasty with 3 vessel disease, at least 70%. Tatlo na. So kaya kailangan ng coronary angiography para malaman mo kung ilan. Okay? So yung magic number mo is 3, or kahit isa lang siya, but if it involves the left main. Remember, the left main coronary branches into LAD, and then you can have also the circumflex around. Or if it's 2 vessel disease but in diabetic patients, remember DM is an CAD equivalent, you have to do cabbage, okay, or coronary angio, arterial bypass graft. Okay, so 3 vessel disease, or pwedeng dalawa lang pero diabetic yung pasyente, or isa lang siya pero what is involved is the left main. So yung mismo talagang yung bungad ng left coronary arteries mo. So if the left main is involved, most likely the LAD, the circumflex, the diagonal will also be involved. Okay? And the marginal. So 2 vessel disease or isa, pwede ka mag-stent lang. Pag 3, and then you have left main coronary or 2 vessel disease in diabetic patients, cabbage. Okay? And we have 2 choices of the grafts. You can have internal mammary artery. It can actually last for an average of 10 years. Okay? Mas matagal siya compared to your saphenous vein grafts, which can last an average of 5 years. So, yeah, depende na yun sa surgeon pa nung gagamitin nila. Pero for information, kasi minsan yung board exam sa Pilipinas, they do not ask about practical things. Minsan mga nonsense yung mga tanong, sorry, pero yun, may mga ibang tanong talaga na parang hindi ko alam kung magagamit ko ba ito sa practice, pero go lang. So sometimes we have to touch on those things, yung mga basic info. So mas durable yung internal mammary, compared to your saphenous vein grafts, which is, I guess, logical. Kasi alam mo naman yung how thick the artery is, right? Compared to your veins. What is the best intervention? I mean, it is the best in this ACS, particularly with ST segment elevation. So that's your percutaneous coronary intervention, which includes angioplasty with stenting, okay? PCI. All right. If you have a question about rhythm, then you do Holter monitoring. Only answer Holter monitoring if you have questions with arrhythmias. Okay, 24-hour monitor para ma-capture mo. Kasi minsan hindi nagpe-present yan while you are doing the test in EKG. Hindi mo makikita yan. Yun. Try natin sagutan ito. A 40-year-old woman comes to the office with chest pain that has been occurring over the last several weeks. The pain is not reliably related to exertion. She is comfortable now and the location of the pain is retrosternal. She has no hypertension. What is the most appropriate next step in the management? So yun, tingnan mo to, 48-year-old woman na naman. Mukhang hindi at risk for CAG by age. And the chest pain has been chronic. The pain is not related to exertion. So mukhang hindi typical chest pain and she is comfortable now. The location of the pain is retrosternal. Mukhang GERD na GERD. She has no hypertension. What is the most appropriate next step? You are not sure of the diagnosis. Holter monitoring, is what I have said, is for arrhythmias. Mukhang hindi ko yan gagawin. Hindi ko rin gagawin yung angiography. So you are left with exercise, echo, troponin, CKMB. I will not do any enzyme testing in the office. So you are left between C and D. That's what I have said. If you are not sure about if whether it's ACS or not, then you do exercise tolerance stress testing. So if the patient's EKG at baseline is normal and then the patient is able to exercise, you can do exercise EKG stress testing. Okay? Ito guys, kailangan natin malaman yung mga evidence for mortality benefit. Kailangan yan. Kasi ang daming questions about interventions. Ang iba, wala namang mortality benefit. In chronic angina, dalawa lang. Okay? Ang may benefit. Beta blockers, which is selective. I hope you still remember your beta blockers with selective property. And your aspirin as well. So yung clue ko lang dyan sa beta blockers, if I remember it right, A to I guess M is selective. Like starts with A, atenolol, bisoprolol, all those stuff hanggang metoprolol. Even beyond the letter M, like pindolol, propranolol, those are non-selective already. Okay? And clopidogrel, like itong Plavix yan sa atin, diba? It is an ADP inhibitor. When do you use your clopidogrel? Combination with aspirin, usually in all ACS. Sometimes after ACS, kailangan mong ibigayan for at least 1 year, and then aspirin indefinitely. Kapag may stent, pwedeng at least 1 month. It depends on the stent na gamit. So, kapag intolerant to aspirin, merong aspirin allergy, you can use clopidogrel instead of aspirin. We can also use clopidogrel in recent angioplasty with stenting. As what I have said, at 1 year after stenting, and then aspirin is given indefinitely for secondary prevention. Merong madaming ADP inhibitors na bago. I think, let's see if I can discuss some of them. So in ACS, madaming issues dyan. Kasi ngayon, merong mga bagong trial that, halimbawa, merong kang patient na nag-ACS, tapos at the same time, merong atrial fibrillation. Siyempre, in atrial fibrillation, you have to give anticoagulation, right? May warfarin kapag valvular heart disease. Pag non-valvular naman, you can give like the NOVAX, the novel anticoagulants, mga Pixaban, Rivaroxaban, Ridoxaban, all those stuff. Pero what if meron kang patient like ACS, tapos may atrial fibrillation? Will you give dual antiplatelet plus the anticoagulation? Triple therapy? So, ngayon, Augustus trial, the latest, do not recommend actually triple therapy because of high risk of bleeding. So what they recommend is you can just choose one antiplatelet. So most of them would prefer clopidogrel plus an anticoagulation, unless the patient has a stent placed within the past 12 months. But pag more than 12 months na, you can do away with the triple testing. even with stroke patients with atrial fibrillation with history of MI. So right now the evidence is robust about one antiplatelet and one anticoagulation. Hindi na uso yung dual antiplatelet plus the anticoagulation. Ang daming risk of bleeding. Right? If the patient is intolerant to both aspirin and clopidogrel, yun. Kasi di ba clopidogrel is used for aspirin intolerance. Paano pag intolerant for both? You have another option, but this drug is actually related to neutropenia and TTP. Okay? I hope you still remember the pentad for the TTP. Okay, so you have a thrombocytopenia, you have a microangiopathic anemia, you have a renal disorder, right? And you also have a fever and neurologic symptoms. So actually, ticlopidin is the drug of choice if you have intolerance for both. Pero dahil nga dyan sa side effect na yan, tinatanong yan, what's the most common side effect of ticlopidin? So it's more on like bone marrow suppression, neutropenia, and some thrombocytopenia as well. Worse lang pag thrombocytopenia na, with like purpura renal affectation with neurologic and fever. So when angioplasty and stenting is planned, halimbawa, sinabi natin, bago makalimutan. Ngayon, most of the time, pag meron kang ACS, sa amin, by institution, hindi na kami masyadong gumagamit ng clopidogrel plus aspirin. Because remember, it will take around 5 days for clopidogrel to be cleared from the system. 5 days, imagine. Yung mga bagong ADP inhibitors, ilang oras na lang or ilang days. Especially yung ticagrelor, yun yung sikat na ngayon. Because of its higher, easier way, to clear from the system yung ticagrelor. Kasi what if, ang case scenario is you have a ACS patient and then STEMI, tapos nag-load ka ng aspirin and clopidogrel. During the coronary angiography, nakita mo na 4 vessel disease, diabetic patient, tapos ang isa pa, left main coronary, so kailangan mo bypass graft, right? Hindi ka makapag-opera kasi nagbigay ka ng clopidogrel, and it will also usually take around 5 days for it to be cleared from the system. Yun yung isang downside ng clopidogrel administration. Pero pag nagbigay ka ng ticagrelor, another ADP inhibitor, you can just go right away with a cabbage without waiting for 5 days. Yun. But here, you have prasugrel and ticagrelor as your choice if ever like you have a plan for stenting and angioplasty over clopidogrel. But between the two, prasugrel is more associated with bleeding, intracranial and any other like GI bleeding. So preferred yung pangalawa, ticagrelor versus the prasugrel. Okay? Try natin itong sagutan. So 64-year-old man is placed on lisinopril, that's an ACE inhibitor, as part of managing CAD. Look at the EF, it's decreased to 24% and symptomatic, okay? And although he sometimes has routes and lung exam, the patient is asymptomatic today. The PE reveals hyperkalemia, which is present in repeat measurements. So refractory persistent hyperkalemia. However, walang EKG changes. Okay, what do you expect from hyperkalemia and EKG changes? You would expect the first, you can have a tented T waves, right? We also have like QRS prolongation, PR depression. Sometimes, pag sobrang taas na like about 8, you can have a sine wave bago yan mag-fibrillate. And yun, so kailangan mong i-resolve yan, yung hyperkalemia. Okay, and once you see an EKG change associated with hyperkalemia, always give your calcium gluconate first before anything else, right? You want to stabilize the cardiac membrane. But in this case, wala, EKG changes are not observed, so wala namang choice din sa calcium gluc, right? So, anong choices mo? Do you add Kayexalid? Do you do insulin and glucose temporizing measure? Do you stop lisinopril? Will you switch lisinopril to candesartan? Okay. So, isa-isahin natin by pharmacology. Sinabi natin, ACE inhibitor ang lisinopril and candesartan is an ARB or angiotensin receptor blocker. Both of these actually could give you hyperkalemia, right? Because it will decrease your aldosterone. And remember, aldosterone reabsorbs sodium and excretes potassium. So if that is inhibited, then you have hyperkalemia. So letter D is not a good option, right? You can have hyperkalemia from both. You don't want to stop lisinopril in patients with likely heart failure with reduced ejection fraction from ischemic cardiomyopathy. You have a history of CAD, right? That's ischemic, and that's a probable reason why you have an EF of 24%. You don't want to stop lisinopril because that has a mortality benefit. Okay, for HFrEF or heart failure with reduced ejection fraction from ischemic cardiomyopathy. So letter C and letter D are wrong. Do you just temporize? A and B are actually temporizing measures. So once you answer questions, you look for, I mean, umbrella term. Diba? Minsan kasi, ang dalawang choices actually would point to one outcome. And kapag dalawa yan, na same lang, don't choose. Don't pick between the two. Okay? Kaya actually, it's just a resin, exchange mechanism in the GI system. Insulin and glucose. Insulin will push potassium with glucose inside the cell to remedy hypokalemia, but you cannot have a lasting effect on this one, because after this one you're still taking lisinopril. You can still have hypokalemia, right? So in this case, especially if this is a African American man, then hydralazine and nitrates would benefit. Okay, you have to switch this lisinopril. Remember that lisinopril is both arterial and venodilators, so it can decrease preload by decreasing venous return. At the same time, it can also decrease your arterial stiffness, so you have a decreased afterload as well, right? And this can be done or achieved by hydralazine and nitrates. Remember that nitrates is a venodilator, so yung veins papunta sa heart will be dilated, so less yung venous return. So it means less yung load sa right atrium, right ventricle, eventually to the heart. So decreasing demand. And then hydralazine is an arterial dilator. So meron din siyang afterload effect. So the effect of lisinopril can be achieved by both, not just by one. Kasi hydralazine only artery, nitrates only vein. Lisinopril is both. That's the rationale why you can substitute lisinopril with the two, and you don't have any hyperkalemia side effect on this one. Well, of course, you have headaches with nitrates. Hydralazine, you can have rebound, reflex tachycardia. Remember, all arterial vasodilators can have reflex tachycardia. Dilate mo yung vessel, then you have hypotension, you can have reflex tachy. So yun lang yung problem sa hydralazine. And nitrates, of course, like headaches, hypotension, because it's a venodilator. Okay? So what are your CAD equivalents where statins should be used in all of them? So remember, statins is an HMG-CoA reductase inhibitors. So meron kang benefit for this in the following circumstances. So you have peripheral artery disease, you have carotid disease, aortic disease. Remember, aortic artery, not the valve, not aortic valve. It should be like aorta. Okay. Meron kang calcified aorta. History of stroke, history of MI, diabetic patients. These patients will benefit from statins. Okay, and the previous goal actually is to decrease LDL to less than 70. But right now, what we do is we calculate the ASCVD, right? The percent 10-year risk of dying, ASCVD risk. You have an ASCVD calculator in the MedCalc. Once it's above 7.5%, then you can start with the statins. Okay, so this is for like secondary prevention. You can do statins. If the LDL, I don't know if I have it here. So if the LDL is more than 190, that's an indication that you can give statin as well, high intensity. I don't know if they will ask about dosing, but there are just two medications for high intensity statins. You have atorvastatin 40 to 80 milligrams, and you can also have rosuvastatin, like half lang, that's 20 to 40. Half mo lang atorvastatin, that's the rosuvastatin. So rosuvastatin is stronger than, it's more potent than that atorvastatin. So yun lang yung dalawang medications for high intensity statins. Yung moderate intensity, lower dose of atorvastatin and rosuvastatin, then all the rest like simvastatin, lovastatin, everything. Okay, so when do you give high intensity statin? For LDL with more than 190, okay, yung level. And for patients na may mga ganito risk, as long as the age is not 75 above, you can use high intensity. For example, 60 years old and may MI before, you can give a high intensity statins. Pero kung MI patient na 78, above 75 years old, you can do a moderate intensity. Okay? And if you have a diabetic patient 40 years old and above, and then you calculated the ACVD risk of more than 20%, then you can do high intensity. If the ACVD risk is less than 20%, you can do moderate intensity. Okay? But if the patient is non-diabetic, and then you calculate the ACVD score of 7.5 and above, okay, you can start with the moderate intensity. It depends on the clinical scenario. Okay? So you have a goal, like after 3 to 6 months, dapat bumaba to by 30 to 50%. Wala pa rin, sobrang taas pa rin ng LDL mo. ACVD risk is still mataas. You can add cholesterol lowering medication, yung prevents like the intestinal absorption of the cholesterol. That's ezetimibe. Okay, so you can add ezetimibe to your statins if ever the LDL is still persistent or the ACVD risk is not modified. And if ever wala pa rin, sobrang resistant pa rin nila, that's the role of your PCSK9 inhibitor. Those are your new medications, the alirocumab, evolucumab, mab. Okay, these are group of, actually the PCSK9, these are a group of protease family that they degrade the LDL receptor in the liver. So remember that the uptake, the clearance of LDL from the blood is via the LDL receptor in the liver. So once na degrade yun, the cholesterol or the LDL will stay in the system. You have a very high LDL. So ang ginagawa ng PCSK9, they degrade the LDL receptor in the liver. That's why mataas. Actually, genetic yun eh. Mataas, especially in familial hypercholesterolemia. Mataas yung LDL in the blood. So what the PCSK9 inhibitor does, it will inhibit that PCSK9 to prevent degradation of the LDL para ma-uptake ng liver yung LDL to increase clearance of LDL from the system. Pero yun yung mga last resort na. So, evolucumab or alirocumab. Okay? So, those are the indications for your statins. Primary and secondary prevention. Pag sinabi kong primary, wala pang sakit, kinompute mo lang yung ACVD risk, more than 7.5, you can start. And then, if my history, then you can do high intensity if less than 75 years old. And then, above 75, you can do moderate intensity statins. Okay? What are the clear indications for the use of statins? Sinabi ko na to, ACS, MI, any arterial disease. Remember the aorta, it should be aortic artery, not aortic valve. Okay? Aortic stenosis is not an indication for statins. Baka malito lang. Okay? Minsan kasi nililito-lito nila mga examinees. And 10-year risk of more than 7.5, that's an indication for statins. Your patient asks you, what's the most common adverse effect of statin medication? Okay? Rhabdo, liver, renal failure, encephalopathy, hyperkalemia. Actually, sila lahat adverse effect. Okay? Pero yung most common dyan that you can explain to your patient that happens in 1% of the cases. Kailangan mong malaman yung 1% na yan para ma-explain mo sa pasyente na kung mayroong may 100 na gumagamit, isa lang nagkakaroon ng liver dysfunction. Kaya most of the time, bago tayo mag-start ng statins, we can get a baseline of the liver enzymes. Okay? Para at least meron tayong basis. Pero hindi necessary that you do like serial liver enzymes measurement while the patient is on statins. Hindi necessary. Just a baseline. Okay? At least makita mo na normal siya to begin with or meron na siyang fatty liver to begin with. Okay? So the most common adverse effect is liver dysfunction. Okay? 1% of the population. The rest of that, letter A, letter C, letter D, and letter E, 0.1% of the cases yung kanilang adverse effect. Okay, that is important to understand. Para at least yung pasyente mo, alam nila. Kasi ngayon, ang dami na naniniwala sa mga, kung ano, mga videos na nakikita, hindi naman evidence-based. Do not routinely use calcium channel blocker in CAD. Okay, be it hydropyridines, dihydropyridines, or non-dihydropyridines. Okay, I just want to remind you, non-dihydropyridines, these are diltiazem and verapamil. They have more action on the heart. Non-dihydropyridines. Okay? Pag mga dihydropyridines, yung mga dipin, di ba? Lodipine, nifedipine, felodipine. So, they have more action on the vascular component. So, more on hypertension. Okay? Hypertension yung kanilang benefit than the heart. So, these medications are not routinely used in CAD unless merong mga certain indications. So, amlodipine, verapamil, especially in acute heart failure, never use CCB because they can block your, remember, they're blockers, so they can block the conduction. At the same time, they can cause some edema, right? Because you have vasodilation and then increased permeability. So, yun yung most common side effect ng CCB. Although, merong iba pa like constipation, minsan may hirsutism pa dyan, pero most common is your edema, peripheral edema. So, do not use, okay? Do not answer amlodipine or verapamil in CAD patients, okay? However, you can answer them in certain cases. What are the examples of these exceptions? If you have a patient with severe asthma that you cannot give any beta blocker, severe ha, hindi lang yung intermittent asthma, mild persistent asthma, severe asthma. Or if you have a Prince metal angina patient, that's an indication for your CCB. Okay, what is Prince metal angina? That's a vasospastic angina, right? You have a classic chest pain, typical angina, and then mukhang tumataas yung troponins, pero pag tinignan mo sa coronary, nag-angiography ka, malinis. And then on provocative testing, merang vasospasm. That's Prince metal angina. So pag ganyan yung case, the answer is CCB. Okay? And cocaine-induced chest pain, never use beta blocker. Okay, this is one contraindication of beta blocker. That's why CCB is the drug of choice for these kinds of patients. Bakit? Remember that your cocaine prevents the uptake of your catecholamines via A2 receptor, right? Alpha-2 receptor. So the catecholamine molecules are actually high in the synaptic space. So you can bind to the adrenergic receptors, so causing unopposed. So if you give a beta blocker in cocaine, the alpha receptors are unopposed. The alpha effect is unopposed. So sobrang taas ng BP, sobrang taas ng heart rate once you block the beta receptor. So never use beta blockers. Remember that. Never use beta blockers in cocaine-induced chest pain. Okay? So that's why kailangan mo ng urine drug screen para malaman mo kung gumagamit ba yan ng cocaine or methamphetamine. And number 4 is inability to control pain with maximal medical therapy. So for example, in stable angina patient, nagbigay ka na ng beta blocker, nag-atorvastatin ka na, nagbigay ka ng aspirin, nitroglycerin, wala pa rin, hindi pa rin effective, maximum dose ka na. You can start giving CCB only in refractory stable angina patients, or minsan ranolazine can also help with that. Okay? So remember these 4 indications of CCB and CAD. Kung wala to sa question, never use calcium channel blockers unless hypertensive lang pasyente mo. So far, so good tayo. Okay lang. What are the adverse effects of your calcium channel blocker? As what I have said, edema. Always educate your patient not to overdose. Ito yung pinaka-common na side effect. And also some constipation. And heart block. As what I have said, kaya nga hindi mo pwedeng ibigay yan sa mga pasyente with acute heart failure. Or may mga patients na may AV block na, meron silang left bundle branch block, fascicular block, never give calcium channel blocker. Kasi nga, by the name itself, it's a blocker already. Okay, and verapamil is very notorious for constipation. Right? Non-dihydropyridines for the heart. Remember, tingnan mo lang yung non na word, N-O-N. Mukhang heart yun, N-O-N. Hindi ko alam, pero wala na. Kasi minsan nalilito sino yung non-dihydro, sino yung dihydropyridines. Pag non-dihydro, heart yun. Okay? Verapamil, diltiazem. Pag mga dihydropyridines, they are more on the vascular. They have more receptors on the vascular component than the heart. Yan yung mga dipin-dipin. Okay? A 72-year-old woman. Mukhang at risk, right? Woman about 55 years old, if this is about chest pain or ACS. Coming in with crushing substernal chest pain for the last hour. Acute. Mukhang ACS to. The pain radiates to her left arm. Yun. Classic na classic. It's associated with anxiety, diaphoresis, and nausea. She describes the pain as sore and dull and clenches her fist in front of her chest. What is that sign called? Yeah, alam ko sinabi niyo, Levine sign. She has history of hypertension. Which of the following is most likely to be found in this patient? Binigay na sa'yo, okay? Mukhang MI to. Hindi mo alam kung STEMI or STEMI kasi wala namang sinabing EKG, wala namang sinabing troponin, pero most likely by the history. Anong makikita mo sa PE? Okay. Tingnan natin kung nalala niyo to. More than 10 mmHg decrease in BP on inhalation. Okay, so remember on inhalation, what do you expect? You expect for a lower blood pressure once you inhale. Why? Once you inhale, increase your intrathoracic pressure, and then, sorry, increase yung hindi pressure, increase an intrathoracic volume, and then the pressure there will increase. That's indirectly proportional. So the pressure will decrease in the intrathoracic region. Therefore, the gradient between the pressure from the lower extremities to the heart is increased. So, mas madaming blood pupunta back to the right atrium kasi mababa yung pressure doon compared sa legs. Pupunta sa right ventricle. Okay? So, mataas yung blood volume sa right ventricle, and in addition to the sucking effect of the lungs once you inhale. So the blood is pulled in the lungs. It's not less of the blood is going back to the left atrium and left ventricle. So you expect that the cardiac output, or the amount of blood that is ejected per minute, is actually decreased. So upon inhalation, it is normal to have a lower blood pressure. Okay, kung meron kang blood pressure monitoring, kung meron kang arterial, line, makikita mo yun pag inhalation, mas mababa sila. That's normal. Pero pag more than 10 ang decrease in BP, that's actually not normal. Right? So that's what we call pulsus paradoxus, right? In cases of like tamponade, constrictive pericarditis, mas mababa yung drop ng blood pressure, okay? That's not normal, okay? And that is most likely related to, that's what I've said, cardiac tamponade, anything that would impair the contractility of the heart. So this one is MI. It doesn't look like this is cardiac tamponade, right? So ayoko mag-answer ng A. That's a pulsus paradoxus. Letter B is increase in JVP on inhalation. So same principle. Kapag nag-inhale ka, malamang dapat the blood would go down from the head down to your heart, right? Kasi mababa yung pressure sa right atrium. So most likely dapat hindi mataas yung JVP, dapat walang distension. So that is what we call Cosmos sign. So A and B actually are common signs seen in tamponade, in restrictive pericarditis, in fluid pericardial effusion. Okay? So I don't think this is what happened to our patient. Letter C, triphasic scratchy sound on auscultation. Ano to? Mukhang pericardial friction rub. Is this pericarditis? Mukhang hindi positional yung chest pain, right? How about letter D, machinery murmur? Mukhang nakikita mo to sa mga patent ductus arteriosus. Parang hindi naman ganito yung picture, right? S for gallop. Ano tong S for gallop? Non-compliant yung left ventricle, kaya meron kang S for gallop. Baka. And PMI displaced towards the axilla. So, saan mo ito makikita? Pag meron kang left ventricular hypertrophy, o meron kang dilated cardiomyopathy, na masyadong malaki yung heart, nag-displace yung kanyang PMI towards the axilla. So, in MI patients, you expect for an S for gallop, right? Because the left ventricle, if the left ventricle is affected, like the left anterior descending artery is affected, hindi masyadong compliant yan. That's why pag bumangga yung blood against the non-compliant ventricle, you have an S for gallop. Okay? So, as what I've said, letter A, letter B, these are signs of constrictive pericarditis or restrictive cardiomyopathy. Letter C is pericarditis, or sometimes makikita mo yan sa Dressler syndrome after a heart attack, like 1 month after you hear a pericardial friction rub. It could be a Dressler syndrome, but usually that's autoimmune related. And letter D is PDA or patent ductus arteriosus. And letter F is more on like LVH or left ventricular hypertrophy or dilated cardiomyopathy. Okay? Ito naman, 70 years old, comes to the ER with crushing substernal chest pain in the last hour. By age, at risk for ECS, substernal, crushing, hindi sinabi kung exertional or relieved by rest, but likely, which of the following EKG changes would be associated with a worse prognosis? So yun, titingnan mo dyan, EKG changes that would portend a worse prognosis in this patient. ST elevation and 2-3 AVF. Anong wall to ng heart? That's inferior wall, right? 2-3 AVF. F, inferior. Usually subserved by your right coronary artery. PR interval of more than 200. This is classic for your AV block, right? Prolonged PR. Letter C, ST elevation leads V2 to V4. So this is like anterior chest wall. Inferior versus anterior. Frequent PVCs. Hindi ko alam kung you would want to treat a PVC in a patient with MI. Let's see later. ST depression in V1 or V2. So pwede itong posterior wall, MI. Kasi pag nag-mirror, kung titingnan mo yung depression ng ST dun sa V1 and V2, usually parang nag-mirror yan ng ST elevation. Pag nakita mo yan, usually that's posterior wall MI. And letter F is a benign finding, right? Bundle branch block. I would not be concerned. Unless if it's a new LBBB, I would be concerned. RBBB is benign. So, kung ako papipiliin dito, letter B is AV block, first degree. Frequent PVCs, that's common in MI patients. I don't want to remember that treating arrhythmia in MI can cause, treating an arrhythmia can cause arrhythmia. That's the rule. So don't be fooled by the arrhythmias in MI patients. Don't treat them. Okay. ST, I would be concerned with ST elevation. We have two ST elevation here. I would choose from between the two of this. So ST segment elevation on the inferior wall versus ST segment elevation in the anterior wall. Siyempre, malilito ka kasi, di ba, alin sa kanila, yung mas nakakamatay. That's actually the anterior wall MI. 30 to 40% mortality, okay, after 1 year. But for like inferior wall MIs, it's like less than 5% in a year. Okay, so mas matatakot ka in anterior wall MI than the inferior wall. So what artery subserves your anterior wall? It's your left anterior descending from the left main coronary. Again, for your inferior wall, it's most likely your right coronary artery. And the management is different. Apart from the, of course, apart from the anti-anginal, after revascularization, there is one medication that you can give for this one that you cannot give for inferior wall, okay? Never give nitrates in patient with inferior wall MI or right ventricular wall infarct. Why? Remember, your right ventricle determines your venous return. So pag nagbigay ka ng nitrates dyan, remember your nitrates are venodilator. So it will decrease the venous return. And now your right ventricle cannot contract because it's infarcted. What happens? Walang makakapunta na blood to the lungs. Walang makakapunta na blood to the left ventricle. Your output decreased. Your cardiac output will be decreased considerably and you can have shock. So in inferior wall MI, never give nitrates. Okay? Kaya kailangan ng EKG lagi. Okay? Hindi pa pwedeng nagsumakit yung chest wall. Of course, emergency response team, magbibigay ka talaga ng nitrates, right? Pero kaya yun yung clue mo. Pag nag-worsen yung pasyente after binigyan mo ng nitrates, nako, baka inferior wall MI yun. Okay? So what you do in these cases, give fluids. Okay? Give more fluids. Kasi in this case, they are preload dependent. They are dependent on the volume status because the right ventricle is not that contractile to provide output to the lungs to the left side of the heart. PVCs should not be treated, okay? Even when associated with an acute infarction, because once you treat that, it can worsen prognosis. That's what I have said. Okay, this one, a 70-year-old woman comes to the ER. Sagot-sagot lang tayo, guys, ha? Actually, it's the best way to learn. Sagot, answer, question, answer. Para ma-exercise yung answer, yung skills nyo to answer questions. So 75-year-old woman, again at risk, kasi more than 55, that's babae, come to the ER with the same complaint. And this time, alam mo na that this is ST segment elevation anterior wall. Okay. The question is, what is the most appropriate next step? Yung next mong gagawin. Okay? Oxygen, nitroglycerin, aspirin, thrombolytics, metoprolol, basta. Mukhang tama lahat sila, di ba? Actually ngayon guys, yung oxygen is not beneficial unless the patient is desaturating to less than 92%. Pag hindi binigay yan sa'yo yung autosat ng pasyente, do not answer oxygen. Okay? Kasi right now, hindi na siya ganun unlike before na lahat, oxygen. So not necessarily if the O2 sat is less than 92%. Unless the O2 sat is less than 92%, give oxygen. Some literature, 90%. Okay. Nitroglycerin sublingual, pwede. Aspirin, pwede ibigay. Do you give thrombolytics? What are your thrombolytics? Lahat na may place na apelyado, altiplase, retiplase. You only give them in N-STEMI, right? Or in STEMI patients na hindi makadating sa hospital within 2 hours. Tingin mo, from probinsya, 5 hours pa, pwede ka mag-thrombolytics muna. I-lyse mo muna yung clot hanggang makapunta doon. Tapos, tsaka pa mag-angioplasty and stenting. Pero wala, hindi ganun yung kaso na binigay sa atin. Metoprolol, pwede to decrease heart rate, pwede to decrease oxygen demand. Atorvastatin to stabilize the plaque. Yeah, diba? Almost lahat sila tama. But what is the most appropriate next step? Kaya sabi ko sa inyo kanina, kailangan nyo malaman which of the interventions have mortality benefit. Among all of those, in acute MI, only aspirin has mortality benefit. Okay? Yung beta blockers mo, pwede mo ibigay yan within 24 hours. Basta within the hospitalization. Hindi siya necessary right on the spot with the ED. Okay? Yan, diagnostic testing. Alam na alam nito. EKG, kailan mo ibibigay, kailan mo gagawin. Immediately at the onset of pain, then pwede kang mag-serial EKG every 4 hours, every 6 hours, right? Myoglobin, ito yung pinaka-first na lalabas sa blood, although very non-specific. And CKMB, also, it actually clears from the system in 1 to 2 days or 3 days. And troponin, ito yung ginagawa natin, diba, most of the time. But if you get this one earlier than 6 or 4 or 6 hours after the onset of the chest pain, usually you ready ka mag-normal troponin, right? And it stays in the system to at least 1 week. So what's the use of CKMB? I don't use any myoglobin. It's not very common. But if they ask you what's the earliest marker that would rise, myoglobin is the answer, okay? Pero halimbawa, after the 3rd day, the patient has recurrent chest pain. Anong kukunin mo? CKMB or troponin? Given this information na CKMB clears in 1 to 2 days and troponin clears in like 7 to 14 days, you don't get troponin after 3 days because for sure it will not give you any additional information because the troponin to begin with is already elevated and it will last for the next 10 to 14 days, right? You will get the CKMB to make sure na wala kang recurrent infarction. Because if you have an elevated CKMB on the 3rd day, it means this is a new infarct on top of the previous infarct, right? So that's the role of your CKMB, to know if there's recurrent after 3 days, recurrent MI after 3 days. Don't retest, you check troponin because it is elevated. Unless you're trending it down, like in cases of questionable MI. Like meron kang ESRD patient, malamang hindi nakiklear yung troponin from the system. Or meron ka lang tinatawag na type 2 MI, yun yung mga demand, high demand, oxygen demand state, like hypertensive crisis, you have tachycardia or atrial fibrillation, mataas lang yung demand, pero not necessarily obstructive yung lesion. So you can have a type 2 MI in that case. That's not a classic MI, the type 1. And you can downtrend, I mean, you can trend the troponin to see if it's, going down to make sure that it's not the true MI, like type 1 MI. So maraming MI types sa type 1, type 2, type 3, type 4, type 5. Pero hindi na siguro kailangan. So may MI dyan na namamatay na, type 3, hindi mo pa na-diagnose, type 4 after stenting, type 5 after a bypass graft. So nagkaroon ng MI ulit. But type 2 is a demand ischemia. So hindi siya necessarily obstructive in lesion. Pwedeng ESRD case, pwedeng sinabi ko na hypertensive crisis or tachycardia related or atrial fibrillation. So temporary lang yung elevation. That's demand ischemia. But for your purposes, yung CKMB is needed to check if there's recurrent infarction. So what measure is associated with the greatest mortality benefit of all ACS management? That's what I've said, it's PCI, right? Or angioplasty. But of course, we have golden period. Kailan sila benefit? Mamaya i-discuss natin. As what I have said, what is associated with decrease in mortality? Aspirin and beta blockers, but they are not critically dependent upon time. That's your beta blockers. Okay? That's why hindi mo siya kailangan ibigay on admission. Pwede mo ibigay, pero alam mo yun, walang mawawala sa'yo pag nakalimutan mo ibigay. Pero just be sure to give it like within the admission. Okay? So time dependent is aspirin, beta blockers, not time dependent, but both of them can decrease mortality in ACS case. Okay, the standard care is that PCI expected to be performed. Expected, so that's a door to balloon time, like from the time that the patient was able to get inside the hospital to the time that the balloon was inflated, actually 90 minutes, okay? Arriving at the ER with chest pain. But the benefit actually would last extended to 12 hours from the onset of the chest pain. And the rule is, if ever the hospital is not capable to do PCI, kailangan mong i-send yung pasyente within 2 hours, okay? Pag hindi nila kayang makarating in 2 hours to that PCI-capable facility, kailangan mo magbigay ng thrombolytics within 30 minutes. Okay? So, thrombolytics in the form of altiplase, retiplase, o anong may place kayo dyan. Okay? So, yun yung clue doon. Pag sinabi nilang rural area, hindi makarating in less than 2 hours, give altiplase first. Yan. And then pagdating doon, mag-PCI na sila. Okay? But door to balloon time is 90 minutes, but the benefit is actually extends up to 12 hours. Okay, so a patient comes to a small rural hospital, yan, without a cath laboratory. Madaming ganyan sa Pilipinas, kailangan pang ipadala dun sa heart center, sa St. Luke's, or kung saan capable facilities. When the patient has a classic STEMI, what is the most appropriate next step in the management of the pain? Yan, transfer to angioplasty, administer thrombolytics now, or consult cardiology. Guys, never answer consult in your board exam. Yun. Kailangan mo muna gumawa ng something before you consult any specialty. So never answer consult. So if you see that one in the choice, automatically remove them, okay, from your answers, possible answers. So in this case, you always have 2 thrombolytics, especially if it would take longer than 2 hours to get to the hospital. Pag less than 2 hours, pwede na, wag mo na ibigay. Okay? Pero unanticipated kasi may traffic pa, hindi mo alam. So it's very, it's fitting to start with thrombolytics while the patient is being transferred. So what are the major and absolute contraindications of thrombolytics na hindi mo maibigay? Like, meron kang GI bleed for the past 3 to 6 months, meron kang hemorrhagic stroke, or even non-hemorrhagic in the previous 6 months. You have severe hypertension to 180 over 105, and you have recent surgery for the past 2 weeks. So yun, you cannot give thrombolytics. So you also have to evaluate this one kung meron kang contraindication. And door to needle time, when you say needle, actually it's 30 minutes. That's what I have said. So kung meron kang, I mean, as what I've said, kung meron kang delay of more than 2 hours, do thrombolytics and do it within the first 30 minutes. So the mortality benefit of thrombolytics, mali pa yung sinabi ko kanina, hindi PCI, but the thrombolytics, it extends up to 12 hours. Okay, so you can do that 30 minutes to 12 hours, especially pag wala ka ng means, sobrang layo, like from Leyte or from Masbate or from any other any continent na hindi makaabot within 2 hours. Okay, ito yung sagutan. Man comes to the ER with chest pain for the last hour that is crushing in quality and does not change with respiration, mukhang hindi pleuritic, or the position, mukhang hindi pericarditis. Okay, so an EKG shows ST segment depression in leads V2 to be V4. And you already gave aspirin. Mukhang N-STEMI, right? Non-ST elevation. Kasi depressed eh. Okay? So, by pathology, pag sinabi mong STEMI, usually, the physiology there is mural ischemia. So, yung buong wall ng myocardium is actually affected, but in STEMI, or like in ST depression, usually subendocardial ischemia yan sila. So hindi ganon ka, hindi pa full yung wall is not affected in its entirety. So kaya mas actually worse yung STEMI, kaya kailangan mo agad mag PCI doon, mag-heparin doon, but in STEMI wala masyadong benefit yung PCI. I mean, kailangan mo muna mag-thrombolytics or heparin. No. Hindi ka magto-thrombolytic sa end-STEMI, okay? So in this case, what will you do? Will you do angioplasty in end-STEMI? No. Morphine can give you benefit as far as pain is concerned, or pwede mo siyang can decrease the preload as well. Nitroglycerin for pain, thrombolytics. But in this case, you're dealing with end-STEMI, so most likely, wait, give me a second. Okay, so our answer here is low molecular weight, like enoxaparin, injectable. Yeah, so for end-STEMI, use low molecular weight heparin. So we will, in the next few slides, we'll give you a summary of everything that we have talked about. Yeah, so if you still remember, just answer me with yes or no kung kailan natin gagamitin yung aspirin, beta blockers in this situation. Okay, so remember that stable angina is not part of your ACS. Okay, so stable angina, to remind you guys, like it's a typical angina. The pattern is not changing, like it's not worsening, the severity and even the frequency, and most of the time is exertional and relieved by rest. Unstable angina, ito yung progressive, more frequent than the usual, and even rest pain, even at rest you have the pain. And STEMI, you have infarction, so you have troponin leak there, and you have ST problems. And in unstable angina, you don't have any troponin leak. Okay, and in the ST segment elevation, you have the ST segment elevation plus the troponin leak. So these two columns belong to your ACS. Stable angina does not belong to your ACS. So in stable angina, unstable angina, and your STEMI, there's always benefit for your aspirin. Okay, aspirin. Beta blockers. When you use the beta blockers, computer. Yeah, so you can also use beta blockers in all of those circumstances. Nitrates, they can also benefit from that. Enoxaparin, your low molecular weight heparin, they are not indicated in your stable angina. Okay, they are indicated in unstable angina. You can also give enoxaparin in STEMI, but only after thrombolytics. So always prioritize the intervention that would lyse the clot first. Ito, wala ka masyadong clot dito eh. Subendocardial lang yung ischemia mo dyan. So prioritize enoxaparin. GP2B3A inhibitor medications, your FTP-batide, terofeban, all those stuff. Actually, hindi siya ganun ka-common, but you can give it in your end-STEMI. And also, sometimes, during stenting, or like, ngayon, pag madami ng cases ng rupture from angioplasty, kasi minsan napapuncture yung wall ng coronaries during the angioplasty or stenting. Meron ding role itong GP2B3A medications. And then thrombolytics, lysing the clot. So remember this, we are talking more about the STEMI. So, but not as good as PCI. Okay, always start with PCI. Only do thrombolytics if madedelay yung PCI. Calcium channel blockers, never use them unless in few circumstances, and you know them already. Aspirin, walang indication yung aspirin as an anticoagulation. That's mostly in atrial fibrillation or indication for like thrombosis. And then antiplatelet drug, yeah, so you only give antiplatelet drug in ACS. Okay, your clopidogrel, ticlopidin, as what we have mentioned, prasugrel or ticagrelor. Okay, so I will give the slides to Abby so she can distribute to everyone. So you can, if you're copying, it's fine. If you're not, then you can have a copy. These GP2B3A inhibitors are best with stenting, as what I've said. May mga fib sa gitna ng word, terofeban, FTP-batide, yun, yung mga GP2B3A inhibitors. Only in stenting, especially in complicated stenting, as what I have said, pag nag-rupture, na-puncture yung arteries, yun, pwede silang ginagamit. And heparin is best for your end STEMI, as what I've said. Okay? Low molecular weight, your enoxaparin, unfractionated heparin, yun yung mga heparin mo talaga na drip. Okay? So, that's best for end STEMI. Okay? Sila yung first na ginagamit mo. Okay? Okay? And then thrombolytics are beneficial only with STEMI. So, you lyse a clot. So, think about how big the clot is. So, in STEMI, that is very significant. So, you have to do that if you have a anticipated delay of PCI. Okay? The next slide is very important. It's about the complications of your ACS. So, very important to know, hindi lang after mo na naka-interview ng pasyente na may ACS, papabayaan mo sila kasi minsan namamatay sila more on the complications ng the ACS itself. Diba? What's the most common cause of death in hospital? That's arrhythmia. Pag nakauwi na sa bahay, the most common cause of death is heart failure exacerbation, right? So in hospital, you have to get clues how to diagnose complications of ACS. So, halimbawa, meron kang pasyente in the third day, meron kang bradycardia, tapos may canon A waves. Ano yung canon A waves? Tingnan niyo muna to. Ito yung waves na nakikita nyo. Actually, makikita mo sa JVD, no? This is A wave, C wave, V, and Y. So, if you still remember your physiology, this is your atrial contraction. Okay, that's your A wave. After contraction of the atrium, the ventricles will contract. And then the mitral valve actually will, because of the ventricular contraction, medyo magkakaroon ng pressure even if it's closed. That's why you have a little bump there, the C wave. Okay, and then once it starts to refill, so it's a V wave. And then once it starts to drain the blood down to the ventricle, right ventricle. We're talking about the right side here. That's the Y wave. So this is the canon A wave. Okay, atrial contraction in the right atrial contraction. So once you have obstruction in the tricuspid valve or merong backflow of blood from the right ventricle to the right atrium, pwedeng mataas yan. Okay? So in patients with, tingnan mo, like after the third day of ACS, nag-bradycardia with a canon A waves, think about third-degree AV block. So what is third-degree AV block? Yun yung mga dissociated atria and ventricle. Remember, we have first degree, second degree, I hope you still remember. So, try ko lang i-recall. So, yung first degree mo, you have a prolongation PR, right? It's more than 20 seconds, like more than 5 small boxes. Constant. Yan, constant lang siya. Na ganun. That's your first degree. Hindi nakakatakot yun. Hayaan mo lang. Most of you might have a first degree AV block. Don't intervene. Okay? Sa second degree AV block, meron kang type 1 and type 2, right? Ang type 1, prolonged yung PR interval mo. Actually, ang second degree, meron kang drop beats. Okay? So, meron kang prolonged PR interval, tapos nagda-drop yung QRS mo. Wala na, hindi na na-follow with any QRS. For the difference between the type 1 and the type 2 second degree AV block, it depends on the character of the prolongation. So, kapag type 1 second degree, the prolongation is progressive. So, ang first PR interval, ganito lang kahaba. Then, ang next, ganito lang kahaba. Ang next na PR, ganito na, pahaba ng pahaba. Then it will drop. So, meron kang warning. That's actually type 1 of a second degree. So, ano lang yan, para maalala nyo, yung parang love life lang. Anticipated mo na, ito, hihiwalayan ako nito. Kasi mukhang may sinyales. Diba? So, yung type 1 ng second degree, actually, wala ka rin gagawin doon. Okay lang, pakawalan mo, walang kwenta yan. Pero pag type 2 ng second degree, ito yung nakakatakot. Kasi wala kang warning na magda-drop beat na sila. As in, prolonged lang sila, constant prolongation, constant, like halimbawa, 0.25 milliseconds. Gano'n lang, prolong lang yung PR, prolong, tapos bigla lang nawala. Okay? Yun nakakatakot. Iiwan ka na wala man lang, wala ka man lang ka-clue-clue. Yun yung type 2 ng second degree. Yun yung kailangan i-intervene. Kailangan mo ng pacemaker doon. Okay? So, first degree, wala kang gagawin. Second degree na type 1, makita mo, may warning nagpo-prolong bago mag-drop beat. Wala ka rin gagawin doon. But in type 2 second degree, yun yung constant yung prolongation with a drop beat in the end. So that's an indication of your pacemaker. Kailangan mong i-pace yun para may source ng, kasi AV block yun eh. So the AV node is not functional. So you have to substitute something to work for the AV node. And the third degree, ito yung nakakatakot. Kasi, alam mo yun, the atria and the ventricles are working on their own. So, regular yung, kung makikita mo yung P wave, regular, yung P wave, interval is regular. The QRS also is also regular. Pero hindi sila nagkakaintindihan. They're dissociated. Okay? So, hindi mo makikita lagi na the P precedes the QRS. Dapat ganun, di ba? The P before the QRS. P, the QRS. Sometimes wala. Basta constant lang sila with each other, like P to P to P to P, they are constant. Pero yung QRS mo, QRS mo is constant then, but they are dissociated. That's a third degree AV block. And that's one of the complications of your ACS. So bradycardia with a dissociated atria and ventricular contraction with canon A waves, the third degree. Bradycardia lang without any canon waves, that's just sinus bradycardia. Pwedeng complication din ng ACS. Sudden loss of pulse. Biglang nawala yung pulse mo and then you see a JVD. That's very scary in ACS patients. You can have a wall rupture. Yung wall mismo yung nag-rupture. Just imagine the heart. Okay? Kasi weakened yun eh. May wall motion abnormality, infarcted, tissue necrosis. So pwedeng mag-rupture yan. Very scary. And then once you have an inferior wall MI history, and then when you auscultate, you have a clear lungs, and you have tachycardia, and then you have hypotension with nitroglycerin. Ito yung clue mo. Nagbigay ka ng nitroglycerin, tapos bumagsak yung blood pressure. That's an RV infarction, right? Inferior wall, right coronary artery. Yun yung clue mo lagi. Okay? Hypotension with nitroglycerin. Bakit clear ang lungs? Kasi nga, hindi na makapag-contract yung right ventricle eh. Hindi na nga makapag-push ng blood to the lungs, right? Kaya clear siya. Bakit tachycardic? Kasi nga hypotensive siya. Bakit hypotensive? Eh, yung right ventricle hindi na makapag-pump to the lungs. Malamang wala nang ipa-flow yung lungs to the left side of the heart. The cardiac output is low. Binigyan mo pa ng nitroglycerin to decrease the venous return, eh wala na. So the intervention for this specific MI guys is fluid resuscitation more than relieving the pain with nitrates. Okay? And then if you have a new murmur, yun, meron kang mitral valve regurgitation murmur. Maybe the valves have ruptured. Okay? And remember, the valves are also perfused by blood coming from the coronaries, right? So coming from the wall. And what if you have a new murmur and you have an increased O2 saturation entering the right ventricle? So you can, actually the catheterization can also give you the O2 saturation in the 4 chambers. So expectedly, dapat yung right atrium mo and right ventricle mo is like the same saturation, right? Kasi galing yan sa right side ng heart, deoxygenated, right? And then the left side of the heart should have an oxygenated blood. But once you see an increase in O2 sat on the right ventricle, isipin mo, bakit parang yung right ventricle ko, blood is as oxygenated as the blood in the left? Baka nga, nag-rupture na yung septum mo. Ah? Remember, the septum is also perfused by, remember that the septum is perfused mostly by your left anterior descending artery, right? Thank you. And then, what if you have a loss of pulse and need for ECG to answer this question? You can have a VFib, right? The most common cause of death in hospital ACS complication. And this one, dinischarge mo yung pasyente, nakauwi na siya, yehey. And then bumalik sa'yo with heart failure symptoms. And when you look at the EKG, there are no changes in the previous EKG. You still have the ST segment elevation. You still have the Q waves, which is an indication of an old infarct. You still have a T wave inversion. This is a classic sign, but it usually happens like months after the ACS. This is a common board exam question: ventricular aneurysm. So yung clue mo dun, you have a heart failure symptoms and then the same EKG findings as that of the previous. So kailangan mo laging evaluate EKG changes. So look for the previous EKG. Tingnan mo kung merong changes, wala. Okay? Right ventricular infarction, what is the most specific finding? So sinabi natin kanina, right ventricle, maka-inferior wall. So isipin mo 2-3 AVF. Pero hindi yun guys, yung pinaka-common na most specific finding. The most specific finding is an ST elevation in RV4. So para siyang reverse, 'di ba? Usually yung ano natin, yung leads natin nasa left side. Okay, so if you put a lead on the right side as well, you will find in the V4 area, if you can find an ST elevation, that's the most specific sign of your right ventricular infarction. Pero minsan wala ka ng time to do that. Your clue na lang is your inferior wall MI picture. So 2-3 AVF is elevated. The ST segments are elevated in that case, and you have a hypotension after nitroglycerin administration. You have a clear lungs and tachycardia. You can assume it is right ventricular wall ischemia. Mitral regurgitation, where do you hear? Mitral regurg is one of the most common valvular defect after an MI. So usually the murmur is best heard at the apex, okay? And then radiation to the axilla. This is always the stem of the question. You have an ACS patient, that's the third day, you have a new murmur in the apex, radiating to the axilla. Think about mitral regurgitation, think about valve rupture, or papillary tendinae rupture. You can have that. And ventricular septal rupture is best heard at the lower left sternum border, because you have a flow between the left ventricle and the right ventricle. So lower siya, left lower. And what's the most accurate test for both valve rupture and septal rupture? Okay, para makita mo. So halimbawa, the third day or the fourth day of MI, may new murmur ka, or tingin mo yung may new murmur in the left lower sternum border, or meron kang murmur in the apex, radiating to the axilla, get an echo. Okay? An echo will give you, kung gusto mo talagang very accurate, do a transesophageal echo. Pero for initial testing, a transthoracic echo is fine. So transthoracic, andito ka lang. Okay, is transesophageal, andun ka sa esophagus to view the posterior wall, especially sa left side. Makita mo accurately yung anatomy ng mga valves mo. And everyone gets what test prior to discharge na hindi nangyayari, pero ideally, dapat meron kang stress test. Unless the patient is still in active pain, and you won't discharge the patient in active pain, right? So, kailangan lagi mong gagawin ito, pero hindi lang nagagawa natin, diba? But ideally, kailangan natin gawin yan. Stress testing prior to discharge. And everyone should go home on mortality benefit medications, aspirin. They should go home aspirin indefinitely, right? And 1 year after for what's this? Clopidogrel or Plavix for 1 year. Kung meron silang stent, at least 1 month. It depends on the kind of stent. Kung metal stent, at least 1 year, 1 month, and then kung yung mga stent na mga bago na ngayon, 1 month pag mga bago, usually 1 year kapag mga metal stents before. Yung mga old model. Beta blockers, statins, and ACE inhibitors. Especially kapag low yung ejection fraction, the ACE inhibitors have better benefit. Or diabetic patients, diba? ACE inhibitors will delay progression of proteinuria, may mga nephropathy, CKD, diabetes, with left this heart failure with reduced EF. Ito, the best ng ACE inhibitors. Okay? Because they can delay your remodeling. And prophylactic antiarrhythmics will increase your mortality. So never give antiarrhythmics to patient with ACS unless they're dying with VFib. Pero VFib, hindi naman antiarrhythmic yung bibigay mo dyan, diba? Defibrillation. And never combine nitrates with what medication? Because they're both vasodilators and they can have a hypotensive crisis. You're a sildenafil, okay? Your Viagra, right? And they can both increase your CGMP. Yeah, okay. And common board question as well, erectile dysfunction after the MI is not from the medication. It's usually coming from anxiety. Okay, so you have to address anxiety. It's the most common cause of erectile dysfunction post-infarction. And the patient does not have to wait after an MI to re-engage in sexual activity. If the patient is symptom-free, usually like 1 to 2 weeks after, sexual activity may begin immediately. Okay? Break muna tayo guys ng 5 minutes. Okay lang?
Yes, yes.
Yes, kuya.
5 minutes.
Ano na.
Hindi, ano lang, ano lang ako. Mag-restroom lang. Saglit. Okay?
Okay, go kuya.
5 minutes. I'll be back. Ayun. Guys, if you have questions, you can type them para masagot natin. If ever you have questions. From the topics that we have discussed, may natutunan ba kayo? May naintindihan ba kayo? Medyo malabo yung iba. Sorry guys, I'm not prepared. Pero mahirap kasi yung wala ka talagang audience na nakikita. So, hindi ko alam yung feedback. Pero I hope may natutunan kayo from the ACS. High yield yun lahat, promise. So, master them. Bulk ng medicine nyo mag-rotate dun sa cardiac issues. Okay? So, proceed tayo sa next topic. It's about dyspnea. Most common cause of dyspnea. Wait lang, bakit nga ito? So, you have a patient with dyspnea, shortness of breath. It's sudden onset, but you auscultated the lungs, it's clear. You have tachycardia as well. You have history of malignancy, obesity, immobilization, hormone therapy. Those are the clues that you have. This is most likely pulmonary embolism, right? Or you have a patient with dyspnea, sudden onset, wheezing, and increased expiratory phase, has allergies, has Sumter's triad, or has aspirin sensitivity. You have polyps, you have allergic rhinitis, you have eczema. That's probably asthma, right? You have a patient with dyspnea, but it's the progression is lower. And then you have fever, you have sputum production, and unilateral rales and bronchi. Chest X-ray can diagnose that. That's pneumonia. You have a dyspneic patients with decreased breath sounds unilaterally in one side with tracheal deviation. Okay, that is your clue. This is likely pneumothorax. Good. You have a patient, a young girl, with caffeine use, history of anxiety. Now, presenting with circumoral numbness, you have, panic attack. Panic disorder is like recurrent panic attack without any trigger, right? Then you have a dyspneic patient, pale, and then it's gradual over days to weeks, easy fatigability, menorrhagic woman or postmenopausal bleeding. That's likely anemia related, right? So another patient, you have like dyspneic patient with pulsus paradoxus. We've already studied that one. A drop of blood pressure more than 10 mmHg upon inhalation. And then you have a decreased heart sounds, and you have a JVD. That's a Beck's triad, right? Hypotension as well. That's your tamponade. Okay. So those are the most likely diagnosis. So don't mess this most likely diagnosis question. These are very easy. So you should get them. Pag most likely diagnosis yung tanong, masaya na kayo. So technique to answer questions, read the question first before reading the question, the stem. Kasi minsan, you can answer the question right away with just the question without wasting your time reading the entire question. Okay? So if the question is about what is the pathophysiology, what's the receptor for COVID, huwag mo lang basahin lahat yung in February, naging pandemic, walang ganun. Okay? So read the question first, and then if you can answer the question without reading the entire thing, then go ahead. You have saved a lot of your time. You have a patient with difficulty of breathing, and then complaining of some palpitations. So you can ask, is it regular? Is it pounding? Is it fast? And then you have syncope. Think about arrhythmia of almost any kind. Okay. You also have a patient with shortness of breath, and then when you percuss the bases, you have dullness to percussion, then history of pneumonia prior. Oh, maybe some fluid. When you look at the chest X-ray, effusion is there. You have blunting of the costophrenic angles. Okay, and then on the lateral side, you have a meniscus sign. That's probably pleural effusion. Right. So as far as like positioning of a chest X-ray, the lateral side is a diagnostic test for your pleural effusion. You can see the meniscus sign right there. And then you have a patient with long smoking history, then barrel chested, shoreball, COPD. Okay, or a patient with recent anesthetic use, and then the blood is brown and not improved with oxygen, and cyanotic with clear lungs and auscultation. This is a classic picture of your methemoglobinemia, right? Or in the case you have a patient burning building in a car, wood burning stove in winter, or suicide attempt, that's carbon monoxide poisoning. And don't rely on the autosat because it's usually high. Rely on the carboxyhemoglobin saturation. The carbon monoxide has higher affinity to oxygen. So, pwedeng mimic like, hindi naman siya hypoxic. Pero cherry red ang skin, and then you have history of, in the garage. Yun yung clue mo from carbon monoxide. So, hyperbaric oxygen, pwede kung cyanide poisoning, you can give thiocyanate, all those stuff. In heart failure, so what is unquestionably the most important of all the tests, that is your echocardiography. Okay, madami ka makukuhang clue dyan. The EF, wall motion abnormality, you can also see the valves. You even can see a presence of pericardial effusion versus pleural effusion. So madami ka makukuha dyan in echocardiography. Okay, that's the best initial test is transthoracic. Okay, yung ilalagay mo lang dyan sa chest. Okay, it's not transesophageal. If you want to look at the valves, like vegetation of the valves, you want to rule out infective endocarditis, then choose transesophageal echocardiography. They have better, they can give you more clues as far as valve structure and abnormalities are concerned. But the most accurate test, not the most common, but the most accurate is your ventriculography or your MUGA, or multi-gated acquisition scan. I don't know if you have it there, but we have it here. Pero we are fine with echo. We're fine with echo. Just for exam purposes, if they ask most accurate test, okay, not echo, it's MUGA or ventriculography. It's the most accurate test. And remember that the best test in evaluating the heart valve function, as what I've told you, is the TEE. Pero usually, pag hindi stable ang pasyente, huwag ka mag-TEE. Ba? Paano mo ilalagay yun sa bibig para makita lang yan, okay? So, just for exam purposes. And then when should you answer BNP, or natriuretic peptide, beta, brain natriuretic peptide? So, BNP in a patient with acute shortness of breath in whom the etiology of dyspnea is not clear, and you cannot wait for an echo to be done. Ang dami lang talagang caveat sa BNP kasi usually in obese patients, they are lower, and in women and in elderly, they're higher. So it's just an adjunct to your echocardiography, but it can help you. It can help you with diagnosing additional clues for your heart failure and exacerbation. Okay, so let's see if you know what test to order to determine the cause of heart failure. Kasi ang daming cause ng heart failure, yeah? Even you have to classify them if they're preserved EF or reduced EF. If it's systolic dysfunction or diastolic dysfunction. If it's systolic, meaning the heart cannot contract adequately, okay, so you expect that the EF is low, right? So systolic heart failure is also equal to heart failure with reduced ejection fraction, right? Pag diastolic dysfunction, it means the heart cannot relax adequately. Okay, there's no problem with pumping, but it's just after pumping, the heart cannot relax adequately, so the filling is low. So that's the heart failure with preserved ejection fraction. So the EF is preserved, okay? As far as the fraction of the blood from the end-diastolic volume to the amount of blood being injected the fraction is maintained. However, the relaxation is abnormal. That's diastolic dysfunction, okay? You have different causes. So if you want to rule out MI or heart block as the cause of CHF, that's why you do EKG, right? You have to see signs of NSTEMI or NSTEMI, ST depression, ST elevation, or T-wave inversions, or blocks. It could be AV block. It could be fascicular blocks. Okay. If you want to rule out dilated cardiomyopathy that is very visible in your chest X-rays, makikita mo yan. Yung heart chamber is more than 50% of the width of your chest. Okay. Dilated cardiomyopathy. It means the wall is very thin, so the contraction is very low. Poor. So that's an actually systolic dysfunction, dilated, which is the most common type of cardiomyopathy causing CHF. If you want to diagnose arrhythmias, that's what I have said, you can catch it through your Holter monitor. Okay. If you want to see the valve diameter, septal defects, you can do cardiac catheterization. It could be right side or left side. If you want to rule out anemia as the cause, you have a high output heart failure in anemia, right? You can also high output in thyroid or beriberi. So those are the common causes of high output heart failure, meaning the heart function is intact. You can still like pump a lot of blood. And in anemia, since the blood is less viscous, then the heart can easily pump it out. So CBC, you give you clue. So ibig sabihin, heart failure, lahat lang related to the heart. So think of other possible causes. Okay. And thyroid also can give you hypo or hyperthyroid can give you heart failure symptoms. Thyrotoxic cardiomyopathy or even hypothyroid cardiomyopathy. For infiltrative diseases, ito yung mga diastolic heart failure. Yung preserve ang kanilang EF but they cannot relax. They're very stiff because they have infiltration. So, less likely ginagawa yan, yung biopsy na yan. But that's the most accurate test. Even in myocarditis, viral myocarditis, you have to see those changes, you have to see those cells, and you can even stain them by refringence for amyloidosis, ferritin for hemochromatosis, all those stuff. Okay? And if you want to differentiate CHF from ARDS, what is ARDS? That's acute respiratory distress syndrome. That is non-cardiogenic pulmonary edema. It means that the pathophysiology is capillary leaking, the fluids are in the intra-alveolar compartment, and then it's more on the inflammatory pathophysiology, but the cause is not the heart. The most common cause of right-side heart failure is left-side heart failure. So if the left side of the heart is normal, and then you see this like bilateral infiltrates, you see the onset of these things is from 1 week of the insult or injury, and then you calculated the PF ratio, that it's a PeO2 that you see in EVG divided by the FiO2. So if it's less than 300, then likely you have an ARDS. It's non-cardiogenic, bilateral infiltrates, and then the onset of injury is within 1 week. It's the Berlin criteria. And then be sure that the left side of the heart is normal. So what do you do to say that, the left side of the heart is normal? Of course, you cannot go into the left side of the heart. Diba? Pwede kang pumunta sa right atrium, right ventricle, pulmonary artery. Sobrang liit na ng capillaries, hindi ka makapasok to determine the status of your left ventricle or left atrium. So what you do is, you do a Swan-Ganz right heart catheterization. So hanggang dun ka lang sa pulmonary capillaries. And remember, the pulmonary capillaries, andun lang yung left atrium mo na. So it can reflect the left atrial pressure. So it's an indirect measure of what's going on in the left atrium. So if the pressure there is normal, like less than 18, then it goes to show that, okay, the left side of the heart is not affected. So likely this is ARDS. The lungs is to blame for this. Okay. So what is the most common cause of ARDS? Still pneumonia. Okay. Septic shock can give you ARDS. COVID, of course, can give you ARDS. And you also have blood transfusion can give you ARDS, pancreatitis, burns, all of those stuff. Okay. But the most common cause is pneumonia. Okay. Please be sure to study COVID, okay? You have a lot of ACE2 receptors in the lungs, okay? You can also have in the podocytes, proximal tubular epithelial cells in the kidneys. You can also have ACE2 receptors in the intestines, the esophagus, the heart. Kaya multisystemic yung affectation niya. Pero primarily it presents with acute respiratory failure via alveolar hemorrhage. Yun yung pathophysiology naman. COVID-19, they attach to your ACE2 receptors. Okay. These agents are given to all patients with systolic dysfunction. So ito sinabi ko kanina, after MI, then you see that the EF or ejection fraction is less than 50%. They benefit from your ACE inhibitors or ARDS because they delay remodeling, and they have benefit with the preload and the afterload. So syempre, decrease yung workload ng heart. Maganda yun, di ba? Yung decrease yung venous return. Once decrease yung venous return, decrease yung preload, malamang decrease yung demand kasi konti lang yung blood na kailangan na ipump. Right? Yan. And also with DM patients, CKD patients from DM, they also benefit from ACE inhibitors or ARBs. Or, not and, okay? Do not give both. You can have like hyperkalemia and renal insufficiency. Okay? You can start with ARBs if the patient has angioedema and cough from ACE inhibitor intolerance, right? But pag wala naman, don't start with the ARBs. Start with an ACE. Ngayon kasi sa atin, mga doktor, agad-agad, losartan, candesartan, hindi pa nga nag-try ng lisinopril, captopril, enalapril, okay? So start with this. This is cheaper than the ARBs. Okay. Which of the following is the most common cause of death from heart failure? Remember, sinabi ko kanina, the most common cause of death in MI, inpatient, is arrhythmia, outpatient cause of death in MI patient is heart failure. Ngayon naman, what is the most common death of heart failure? It's still arrhythmia or sudden death. Okay? So do not underestimate heart failure. They can present with MI and arrhythmias. Remember this one, guys. Mortality benefit in systolic dysfunction or low EF heart failure. As what I have said, ACE inhibitors or ARBs. Beta blockers, only these 3 medications. Right? Memorize them. Carvedilol, bisoprolol, and metoprolol. Now for metoprolol, remember we have 2 types. We have metoprolol tartrate and we have metoprolol succinate. So between the 2, it's the metoprolol succinate that has the mortality benefit. So they might put the 4 drugs, metoprolol succinate, metoprolol tartrate, bisoprolol, and carvedilol. Do not choose tartrate. Tartrate is short-acting. They are only beneficial in patients with like acute increased or elevated blood pressure. Gusto mo lang i-remedy yung kanilang acute blood pressure, you can give tartrate. But succinate is long-acting. You can give it like once a day. Okay? And remember, sinabi ko kanina, A to M, letter A to M is usually selective. Diba? Beyond the M letters, the first letter, they're non-selective beta blockers. So metoprolol is a selective beta blocker. Bisoprolol is a selective beta blocker. Carvedilol is non-selective even if it starts with C. Okay? Because hindi siya actually selective siya to beta 1 than the beta 2. But it has an effect on the alpha as well. That's why it's non-selective in a sense that it has an alpha adrenergic antagonistic effect. Okay? Pero maganda siya kasi meron ka ng alpha inhibition, may vascular component ka doon, meron ka pang beta 1, which is the heart component, right? Okay. Spironolactone, these are your mineralocorticoid receptor antagonists. They are very helpful in patients with like heart failure symptoms, NIHA class 3 and 4, yung severe na. So, but be wary with spironolactone for hyperkalemia because these are potassium-sparing diuretic, right? Tapos meron ka pang ACE inhibitor. So always monitor your kidney function and electrolytes once your patients are on these medications. And your goal for beta blocker is at least like a 60 of heart rate. Dapat yun. Pag halimbawa, 90 pa yung heart rate ng pasyente, pwede ka pa mag-up titrate ng medications. Goal mo is 60 to 70. And the blood pressure is at least 130/80. So those are the goals for titrating the beta blockers. And if the patient is intolerant to ACE inhibitors because of hyperkalemia, you can use hydralazine plus nitrates. These are very helpful in African Americans. So our patients here are like 80 to 90% African Americans. They're the sickest people in the world. Grabe, ang lala. Sobrang, pag medication reconciliation ka, mababa lang yung 15 medications in one patient. Sobrang nakakahilo. May mga transplant patients, may cancer patient, all in one body. Okay, so in African Americans, since they have actually very, very interesting because these people have a low renin phenotype. They have like mutation in their genes that the renin is found to be low in them. That's why in African Americans you don't start with ACE inhibitors or ARBs because they have low renin phenotype. So kung low ang kanilang renin, they have a low RAS system, right? Mababa yung renin, angiotensin, aldosterone, so wala kang iba-block. So ACE inhibitors actually do not really help with African Americans as far as controlling hypertension is concerned, okay? Because of this weird genotype that they have. That's why we would rather start them on calcium channel blockers for hypertension, to be specific, than ACE inhibitors. Okay, but once they have heart failure, then you go with ACE inhibitors because general yung benefit nila, regardless of the race. However, if they have intolerance to this because of hyperkalemia, then choose hydralazine plus nitrates. Not just hydralazine, not just nitrates, plus, because that's what I've said. Hydralazine is arterial dilator. Nitrates is a venodilator. Combined effect yan ng ACE inhibitors. And then, in a paradigm HF trial that came out lately, sacubitril and valsartan combination is also very helpful to those patients who are tolerant to ACE inhibitors. Like gusto mo pa ng better control with the heart failure symptoms, and they are tolerating ACE inhibitors, they don't have any problem with lisinopril, you can actually shift them to this combination. The valsartan, this is an angiotensin receptor blocker with an iprilizine inhibitor, sacubitril. So this medication combination as well has a mortality benefit in heart failure with reduced ejection fraction. But be sure that before starting this one, they are tolerant to ACE inhibitor. They don't have any hyperkalemia. So what we do is we try to test them like 48 hours to see if they don't have any hyperkalemia, and then we switch them to sacubitril. But there is an overlap. There should not be an overlap. There should be a wash out, like 1 to 2 days. The ACE should be out of the system before giving this one. Because of course, logically, if you still have this one in the system and then you add valsartan, then you have accumulated side effects of the medication. And then ICD, implantable defibrillator. If they have like symptomatic and NIHA 3 and 4, and then be sure that you have tried all these medications. That's the goal, medical directed therapy, GDMT, for heart failure patients for at least 6 months. If after 6 months they still have the symptoms, pangit pa rin yung heart rate, then ICD is indicated. Okay, but be sure you start with a with a pharmacologic therapy or medical therapy before inserting an ICD, unless they have arrhythmias while in hospital as a consequence of heart failure. But if they don't have any arrhythmia, ICD is not indicated. Okay. Diuretics control symptoms of heart failure. Of course, they're always congested when they come to the hospital. Okay, so if there's one medication that you have to choose, diuresis them. Okay, makikita mo yan sa chest x-ray nila, bilateral infiltrates, pulmonary edema, and they increase BNP, and they're non-compliant with their medications. They've been eating a lot of high sodium diet for the past few days. Ganun yung picture ng mga African Americans. Although they do not lower mortality, the diuretics is for controlling the symptoms. Okay, so just a clue: most of these patients are on oral diuretics. So what you do is use the same dosing. Like for example, they're on 40 milligrams of furosemide. What you do is just convert them to IV. So give a 40 IV, because IV is twice potent than the oral. So it's like as if you're giving 80 milligrams of oral. That's equal to 40 milligrams of IV. Okay, so after giving like that, converting the oral to IV, you have to monitor the urine output of the patient. Pag hindi pa rin, bigay ka ng higher dose. Like if you started with the 20 milligrams of IV, wala pa rin output, you can increase to 40 milligrams of IV. Pag wala pa rin, give another diuretic. Actually, the metolazone can help. Okay, it's like a thiazide diuretic that will augment the effect of the furosemide or the loop diuretics. Yeah. In diastolic dysfunction, these are the people with preserved EF. So they don't have problem with contraction. The heart is able to contract well, maintaining the EF, but the relaxation phase is not good. So they have poor filling capacity. So actually, there are only 2 medications that are helpful for them: beta blockers and diuretics. Okay. Remember, yung binanggit natin kanina, yung ACE inhibitors, spironolactone, hydralazine, sacubitril, valsartan, your beta blockers, yung tatlo, they are only helpful in heart failure with reduced ejection fraction. Only these 2 actually are used in preserve. Kaya kailangan mong malaman kung preserve ang EF, get the echocardiography. Sometimes you do a bedside echo. You can have a clue kung okay yung systolic function, pero you have to have a formal echo to tell you how much ejection fraction the patient has para makapag-decide ka kung anong gagawin mo. Okay? Most of the time is to reduce ejection fraction, ischemic in nature. Most of the time in this preserved EF, hypertension is the cause. Pero meron ibang infiltrative diseases. So more on diuretics and beta blockers. Okay? Yung ACE inhibitor, hindi masyadong ginagamit. Spironolactone, hindi masyadong ginagamit. Yung sacubitril, valsartan, hindi masyadong ginagamit. Okay, you have this patient, 74-year-old woman, coming to the ER with acute onset of shortness of breath, tachypnic to 38, with RALS to her apices, and S3 gallop, so NJVD. So it looks like the patient has a right-sided heart failure, right? may jugular vein distension ka. S3 gallop is very specific for like volume overload, right? And you have to keep niya shortness of breath. What is the best initial step in the management of this patient? It looks like this is a heart failure patient, right? What will you do when you set it time metoprolol? That's what I have said. If this is a volume overload patient, you have to diuresis the patient. That is for control, symptomatic management, but does not offer any mortality benefit. Okay, so you have after that one, do echocardiography and see if the EF is low or high, and then proceed from then on. Okay. So summary of acute pulmonary edema management: preload reduction. Preload means the amount of blood going back to the right side of the heart. So you can do nitrates, is the venodilator. Morphine, apart from giving you analgesic effect, it can also help with reducing the preload. That's why ito binibigay ito sa mga pasyente na mamatay na. If hospice care patient, ayaw mong mahirapan sila, bigyan mo ng morphine every 2 hours to make them comfortable. That's also preload reduction on top of the pain effect. Loop diuretics, of course, kung mababa yung blood volume mo, mababa din yung babalik na amount of blood to the right side of the heart. Oxygen one way or another, but not directly. Positive inotropic effects. Halimbawa, may have a heart failure patient, sobrang baba na ng EF, 10% na lang, ganon, 5% na lang. You can give dobutamine, which is beta-1 receptor agonist more than the beta-2. Remember, beta-1 is for the heart contraction, beta-2 is more on the vascular dilatation. Inambrinone is also is a PD3 inhibitor. Can give you increased cyclic AMP and give you some inotropic effect as well. Digoxin has positive inotropic effects with negative chronotropic effects. So you have a low heart rate in this patient, okay? But they don't offer any mortality benefit. They can just reduce the rate of hospitalization heart failure patients, but they're not the first line. They're also toxic, like narrow therapeutic index. So you can have a lot of electrolyte imbalances. You can have halo, green halo, side effects, all of those stuff. And if you have an AKI, you have decreased excretion of digoxin. Be sure you know the antidote if you have digoxin toxicity. And then afterload reduction, ACE inhibitors. Also in ACE inhibitors can also reduce preload. So pwede may lagay dyan ng ACE. ARBs, nitroprusside, and IV hydralazine. So what I've said, hydralazine is an arterial dilator. What is unique about nitroprusside is it acts both on the venous and the arterial system. That's why this is one of the drug of choice for hypertensive emergency. Because in hypertensive emergency, you decrease the afterload, decrease the arterial stiffness, as well as the venous. You can benefit from venous dilatation. So decrease preload. You can have decreased incidence of flash pulmonary edema, because most of the time patients with hypertensive crisis also has pulmonary edema. Okay. And the onset of the digoxin actually takes weeks. So hindi mo yan makukuha agad like acute. And you have to monitor the level, stop at 0.9, 0.5 to 0.9, not more than 1, kasi toxic na yan. Yeah. So medyo hassle lang yung digoxin when it comes to monitoring. But they have certain benefits, especially in heart failure patients and also in atrial fibrillation patients with low EF. Yeah, you can give them, especially pag hindi rate controlled with beta blockers, yung mga fibrillating heart with calcium channel blockers. Okay pa kayo, guys? Nakakasunod pa kayo? Sabi lang ha, pag mabilis. Yun. Valvular heart disease na tayo. Anong oras na ba? Kaya niya pa? 8:49. Madami na tayo na cover. Okay. So, valvular heart disease. Few tips. Okay? General concept. So, kailangan talaga dito na intindihan mo anong nangyayari. Huwag mag-memorize. Okay lang mag-memorize pa konti-konti, but be sure you understand the concept para kahit balik-balik rin ka, kaya mong i-analyze ang mga tanong. Okay. Lesions on the right side of the heart. So, we are talking about the valves in the right side. So, we're talking about tricuspid valve, and we're talking about the pulmonic valve. Pag pulmonic valve, hindi masyadong tinatanong yan unless congenital yung cause. Like, you have a tetralogy of Fallot patient. Yes, pulmonic stenosis is the most common cause of mortality or yung symptoms nila. Pag right side, usually tricuspid ang pinag-uusapan natin dyan pag adult patients. Okay? Remember that the lesions in the right side of the heart increase in intensity with inhalation. The principle always is like this. The murmur is increased once there is increased differential pressure between two compartments. For example, between the right atrium and right ventricle, pag mataas yung gradient nila or difference ng pressure nila, mas malakas yung kanilang murmur intensity. Yun yung principle. So, any lesions in the right side of the heart would increase in intensity with inhalation. Why? Pinag-aralan natin kanina, upon inhalation, the intrathoracic volume is increased but the pressure is lower than that from the lower extremity. So, madaming babalik na blood back to the right atrium and right ventricle. So, highly likely magkakaroon ka ng differential pressure. Madaming dugo, mag-rush yung blood then doon. So, pag meron ka mga stenosis or regurgitation, then you can accentuate the intensity of the sound of the murmur. However, it's the opposite side. So, isa lang i-memorize mo. Right side of the heart, inhalation. Ay malamang. Ang left side, exhalation. Exhalation, doon naman sa kabila yung mag-increase. So, we're talking about the mitral valve and the aortic valve. These two valves are commonly asked. Okay? Then the right side. Okay? Siguro yung right side, pag meron ka lang patient with IV drug use history, tas nagkaroon ng fever, nagkaroon ng new murmur, think about, it could be right-sided infective endocarditis. So most likely, tricuspid yan or pulmonic, pero less likely pulmonic. Doon muna yan sa tricuspid kasi first siya dadaan doon. Ba? Ay, hindi naman makakaabot sa left side yung emboli kasi ano ka sa pulmonary capillaries mo. Okay? So most likely, pag may IV drug user na may history or may clue ka na parang infective endocarditis, then right-sided yan. Okay? Endocarditis prophylaxis. Yung mga bibigay ka na amoxicillin bago bunutan ng ngipin. Kailan ka magbibigay nun? Okay? May mga indications lang yan, guys. Hindi lahat. Okay? So, magbibigay ka lang kapag meron kang history of valve replacement before, meron siyang history ng previous endocarditis, o kaya meron siyang cyanotic heart disease na hindi na-repair, or cardiac transplant patients. Yun yung mga kaso na bibigay ka ng amoxicillin prior to any like dental procedures na involves bleeding, a lot of blood, bloody procedures, or kahit respiratory or GI procedures na may kinalaman with mucosal biting or involved with some risk of bleeding, then you do prophylactic. Most common medication used is amoxicillin. Ito, very, very, very important. Madaming tinatanong dito about the maneuvers and effect nila to the murmurs. Let's just understand them. Okay? So, ito. Kung meron akong sasabihin sa inyo lagi, ito lang yan, about the valvular heart disease. Think about the two unique valvular disease that gives you unique manifestation. MVP and hypertrophic obstructive cardiomyopathy, HCO. Okay? HOCM and MVP. Ito yung dalawang weird. Sasabihin ko mamaya bakit weird sila. Okay? So, this time, we're talking about the effects of squatting, leg raising, standing, and Valsalva. Do not memorize. I want you to understand the concept. Okay? We're talking about preload here. Okay, so the first part is about the preload. Remember, the preload is the amount of the blood that goes back to the heart, okay, regardless of the respiration cycle. Squatting or leg raising, do you anticipate a higher venous return or low venous return? Nag-squat ka, na-compress yung vessels mo. In the lower extremities, the pressure is high. It will push a lot of blood back to the heart, right? If you raise your leg, of course, more blood is going back to the heart. So this first column is giving you a clue that you're increasing the venous return back to the right side of the heart, right? Okay. And if you can see, all the aortic and the mitral valve problems is directly proportional to the venous return, the effects on the intensity of the murmur. So kapag mataas si venous return, Mitral aortic stenosis, mitral aortic regurgitation, murmurs are also increased. Itong dalawa, weird. Look at this. The murmur in MVP and HOCM is decreased once the venous return is low. Kaya unique sila. Bakit? Isipin na yung HOCM, hypertrophic obstructive cardiomyopathy. Hypertrophic, makapal yung vessel ng makapal yung wall ng heart. Even the septum is thickened. Kaya nga, pag makita mo yun sa pathology, di ba? Disarray of the myocardial fiber. Sobrang kapal ng septum nila. Okay? That once you increase the venous return, isipin mo ha, yung heart mo na may HCOM, makapal yung septum, yung cavity niya is very small because nga the septum is very thick. You have to distend it, you have to expand it, you have to increase the chamber size para ma-relieve mo yung obstruction, di ba? So once you squat or you do leg raising, the venous return increases, madaming blood babalik sa heart, to the right side and then to the left side, and then the chamber cavity will increase. Okay, that's why the murmur is decreased in HOCM once you increase the venous return. Does that make sense? Okay, how about mitral valves prolapse, sir? Well, you know the mitral valve prolapse, diba? Pag nag-contract ang mitral ventricle, okay, once the leaflet goes up, they have a space in between, they do not coaptate, okay, easily, okay. Minsan naman, sobrang lapit nila that they, ganito, gumagano sila. Hindi sila nagko-coaptate completely, kaya meron kang regurgitation back to the left atrium. If you increase the chamber size by giving back blood, by having increase the venous return, mag-expand yan, and most of the time, kapag nag-coaptate, kapag contract yung mitral, the left ventricle, they can coaptate in a way. Kasi minsan kapag MVP patients, actually hindi sila symmetrical or hindi, the coaptation doesn't go together. There's problem with the leaflets, function. So more likely, once you increase the cavity size, you can at least increase the chance of closure. That's why the murmur is also decreased. So, kaya very unique siya. MVP and HOCM indirectly proportional. Increased venous return, decreased the murmur sound. And don't memorize the standing and Valsalva. Why? Because standing and Valsalva can decrease the venous return. Right? Once you stand, there's less blood going back to the heart. Once you do Valsalva, okay, you have an increase in abdominal pressure. You can decrease the venous return. And if the venous return is decreased, opposite mo lang yan sa MVP and HOCM. Right? So just memorize this part of the slide. MVP and HOCM, opposite. Increased venous return, decreased murmur. The rest of the valves, pareho na yan sila. They go in the same direction. I hope that makes sense. Okay. Dito naman, we have hand grip and amyl nitrate. So this one naman is talking about our afterload. The previous slide is more on the preload, right? Ito naman is hand grip. Isipin mo nag-hand grip ka sa physiology. I hope you still remember. Okay, you have increased afterload. Amyl nitrate. Nitrate is a venodilator, right? Pero itong amyl kasi parang may component siya ng arterial dilator. So this is decreasing afterload. This is increasing afterload. Look at the MVP and HOCM. Okay, increasing the afterload in hand grip will decrease the murmur in these two situations. And amyl nitrate, opposite. The rest, wag mo nang pansinin. Even don't memorize this no effect in mitral stenosis. Mahirap na yun, alalahanin. Always remember the two valvular disease that have exceptions. Okay, they go opposite way. Mitral valve prolapse and HOCM. Okay, HOCM is seen in athletic patients. They have sudden cardiac death, family history. Think about that. Once you increase the venous return by squatting and leg raising, you decrease the intensity of the murmur. Once you increase the afterload by hand grip, you also decrease the intensity of the murmur. So opposite siya lagi. Increase preload, increase afterload, decrease intensity of the murmur in these two valvular disease, and the opposite way. decrease preload, decrease afterload, increase the intensity of the murmur in MVP and HOCM. Okay? Yun yung palagi tinatanong yung dalawang yan. Ang MVP naman is common in, young women, may mga anxiety attacks, OA, gano'n, anxiety, hiwalay ng boyfriend, pumunta ng ER, gano'n. Hindi mo alam may MVP pala. Kaya don't underestimate. May mga legit naman talaga na complaint, okay? In these cases, you just have to give beta blockers. That's symptomatic control. Pero pag may MVP na may history of stroke, mag-isip ka, baka hindi lang MVP yan. So sometimes in recurrent stroke in patients with MVP, wala ka na ma-identify na cause. You can start with any anticoagulation and even antiplatelet like aspirin and warfarin. But those are only happening in rare cases. Okay? Most of the time, relieve anxiety, psychiatric consult, or beta blocker for symptomatic relief of anxiety for patients with MVP. Best initial test in all valve disease, it's TTE. Okay? Transthoracic. You can see the valves there very clearly. But more accurate than TTE, as what I have said, if you want to look for vegetation, you want to look for papillary elastoma or any atrial myxoma, then you can do transesophageal echocardiography. Okay? And the most accurate test, okay, different yung mga initial test, more accurate, most accurate. Okay. So most accurate test is cardiac catheterization. Kasi papasok ka talaga dun sa vessel, papasok ka sa right atrium, papasok ka sa valve, makikita mo yung pressure, makikita mo even your oxygenation, tapos papasok ka sa pulmonary capillaries. Kapag left heart cath naman, dun ka papasok sa artery, then go to the left atrium, left ventricle. Sorry, left ventricle muna kasi artery ka, aortic artery, left ventricle, then left atrium. Pero usually hindi na ginagawa yun. Hanggang coronaries ka lang for the left heart cath. Pero for cardiac cath, you can have a better view, and even you can get more clues about the diameter of the valves and even the oxygenation status within the chambers of the heart. Okay. In mitral stenosis, what is the most often cause of MS? You know that is rheumatic fever. Okay. So in these cases, kapag mayroon kang mitral stenosis, valvular, mayroon kang atrial fibrillation in the setting of mitral stenosis caused by rheumatic fever, warfarin is always the answer. Okay? So pag valvular atrial fibrillation, warfarin is the answer. Pag non-valvular, kailangan may echo ka lagi para magamit mo yung mga apixaban mo, magamit mo yung endoxaban mo, rivaroxaban. Kailangan non-valvular ang cause ng atrial fibrillation. You can use them. Maganda kasi yun kasi wala kang INR monitoring, ba? Hindi kagaya ng warfarin na kailangan mo INR monitoring, kailangan between 2 to 3, di ba? Pero pag halimbawa, ang valves mo is mitral and then it's artificial, hindi siya bioprosthetic, mas mataas. Yung goal mo like 2.5 to 3.5. Right? Pero kung usual atrial fibrillation lang non-valvular, usually the goal is 2 to 3 of INR. Okay? Mas mataas ang risk, guys, ng embolic stroke in mitral valve than the aortic valve. Okay? Kaya mas mataas usually yung kanilang threshold for INR 2.5 to 3.5. Okay? Mitral stenosis kapag less than 1 cm, yan. That's critical narrowing. And the main indication for mitral stenosis is the presence of symptoms. Okay? They always ask breathlessness, exercise intolerance. Ang clue lagi dyan, guys, kasi ang hirap i-memorize ng management ng valvular disease. Usually, pag aortic, hindi lahat ng pagkakataon, usually pag aortic, valve replacement is the answer. Usually, pag mitral, valve repair is the answer. Okay? Kasi magkapareho, almost the same lang yan. Bibigyan ka ng kaso, bibigyan sa'yo ng Tapos aortic stenosis, matanda. What will you do? Calcified, replace or repair? Guys, huwag ka na mag-repair. Palitan mo na yan, di ba? So most of the time, aortic cases, replace. Most of the time, but not all the time, mitral problems, be it regurgitation or stenosis, repair. Sometimes valvotomy. Okay, bubutasan mo kasi minsan sobrang stiff nila. So it's still part of repair, right? So mitral is repair, aortic is for replacement. Okay. So unique features in mitral stenosis, you have dysphagia. Okay, Bakit? Bakit, Doc? Bakit may hoarseness? Bakit may atrial fib? Bakit may hemoptysis? Dali lang. Isipin nyo, mitral stenosis, ibig sabihin, pag-relax ng ventricles, okay, dapat yung blood will flow from left atrium to left ventricle. But since it's stenosed, the blood cannot go down during relaxation phase. So it stays in the left atrium. The left atrium will enlarge. And remember, the left atrium is proximal to your recurrent laryngeal nerve. Okay, you can have hoarseness. And remember, it's also proximal to your esophagus. That's the nearest, that's the closest chamber to the esophagus. That's why you also have dysphagia, right? And once the atrium is stretched, it also can affect your atrial appendage, yung maliit na parang tongue-like structure. And that's the most common site of your atrial fibrillation. You can have hemoptysis because you can erode some of the vessels, okay? Bronchial artery as well. That's why you can have these symptoms, okay? Chest x-ray finding, you can have a second bubble. Remember, you only have a single bubble for the aortic arch. You can have a single bubble, second bubble there for the enlarged left atrium behind the heart, and then you can have straightening of the left heart border. Pwede mag-straight yun. Wala na siyang curve. Kasi nga, enlarged yung left atrium. And also, you elevate the left mainstem bronchus. Okay? So, instead na ganito siya, pwede mag-elevate. Okay? Because parang napupul siya ng left atrium. Okay? And the murmur in mitral stenosis, it's diastolic. Kasi nga, di ba, upon relaxation, the blood should flow from up to down. But since you have a stenosed valves, then you can have diastolic murmur after an opening snap. So yan, pag makita mo yung opening snap, boom, mitral stenosis to. Yan. Yung mga keywords mo. Pag mid-systolic click, boom, MVP to. Right? So yun yung mga kailangan mong malaman. EKG finding because of an enlarged atrium, you can have a biphasic P wave in V1 and V2. Remember that the P wave, actually yung P na yun, yung mountain ng P na yun is divided into two. The first half is from the right atrium. The second half is for the left atrium. Okay? Kapag masyadong, kasi the SA node is in the right atrium, right? The conduction should travel to the entire right atrium, go to the left atrium bago pumasok sa AV node. Okay? So, kapag matagal masyado yung journey ng conduction from the right, the left atrium, the P wave will prolong. So, normal sana yung first half mo, pero kasi na-prolong sa left, kasi nga malaki yung left atrium mo. So, na-prolong, kaya nagba-biphasic siya para siyang nag-EM. Okay? P mitrale yung tawag doon. That means the left atrium is enlarged. Pag right atrium naman ang enlarged, you have a peaked P wave. Kasi nga sa first part pa lang ng source ng SA nodal conduction, mahaba na yung journey niya, kaya peak P wave is for right atrial enlargement. For biphasic prolonged P wave is for left atrial enlargement. Okay. What do you do? Sipin mo, mitral stenosis, hindi maka-flow yung blood from the left atrium to left ventricle, so babalik siya to the lungs. So likely pulmonary edema is the consequence, right? So what do? I have to reduce the preload kasi nga madami ng tubig sa lungs, tapos dadamihan mo pa yung balik na dugo from the right side of the heart. So you diurese the patient, okay? Sodium restriction. And that's what I have said, kapag mitral, repair. Okay? Sobrang rare lang nangyayari itong replacement. Okay? Magre-replace ka kung sobrang na talaga. Like, may vegetation na doon, sobrang damage na yung mitral valve mo, hindi na kayang i-repair. Pero most of the time, kapag stenosis, pwedeng valvotomy or valvuloplasty. So repair first before the replacement. Okay? Let's go to aortic stenosis. So stenosed yung aortic valve mo. Very common to sa mga elderly, calcified yung kanilang valves. Or congenital problems, look for bicuspid aortic valve. Remember, tatlo yung valve sa aorta mo. Right? Tricuspid, tatlo yung sa right mo, pero yung mitral mo is only bicuspid. So yung aortic mo, tatlo yan. Pero kapag nag-bicuspid yan, they are at a risk of having aortic stenosis. So that's the congenital predisposition to an aortic stenosis in younger patients. Pero most of the time, nakikita mo ito sa elderly. Right? The most common presentation is angina. Bakit? Kasi isipin mo, stenosed yung aortic valve mo. Once the left ventricle pumps, there's not enough blood going out, and During relaxation, that's the only time that the coronary arteries are perfused. So you have problems with that, with the perfusion to the rest of the system, as well as the problem with relaxation, problem with the perfusion in the coronary arteries. And you also have a clue na meron kang carotid, what's this, radiation of the systolic crescendo decrescendo murmur to the carotid. Yung clue mo na may aortic stenosis ka. Okay? And the murmur is what I've said is systolic, because once the left ventricle pumps, okay, it runs against the stiff aortic valve, and it's crescendo decrescendo. So para siyang diamond shape, palakas tas pahina. So you hear this between the S1 and the S2, right? After the S2, there's diastolic murmur. So systolic, crescendo decrescendo with radiation to the carotid arteries. Yun yung clue mo. This is an aortic stenosis. And where do you find where is it loudest? It's in the second intercostal space in the right ICS, right? Right parasternal border. R for right? And then pulmonic valve is located on the other side. Pulmonic, you have a letter L there, left. Both of them are in the second intercostal space. Pero ang isa nasa right, which is aortic R, ang isa nasa left, pulmonic, which is left. Okay? Yung mitral mo nasa baba na yan. And yung tricuspid mo nasa fourth intercostal space na yan. Left parasternal border. What do you see in EKG finding? Since the aortic valve is very, very stenosed, you expect that the left ventricle is also enlarged, right? Kasi nga, hindi, yung left ventricle mo has to face a very increased afterload because of the very stiff aortic valve. So the left ventricle will start delayed, eventually hypertrophy. Okay? And I know you know the Sokolo-Lyon criteria. Look at the S wave in the V1 and then the R wave in the V5 or V6. Add mo yan silang dalawa. Kapag umabot yan ng 35 mm, yung small boxes, more than 35 mm, that's like the hypertrophy. Okay? Minsan napaka-subtle nila. You can get a clue, what we call the modified Cornell criteria. Look at the AVL. If they're more than 12 mm, kahit wala pa yung Sokolo-Lyon criteria, like the S in V1 plus R in the V5 or V6, kahit hindi pa yan umabot ng 35, pero you are very suspicious of LVH, kita mo sa chest x-ray, napakalaki ng heart. Look at the AVL. Okay, sometimes you can get the clue there. If it's more than 12 mm, then likely that's a left ventricular hypertrophy. What is a true, only effective therapy in aortic stenosis? Alam niyo na yan, guys. Pag aortic, replace. Mitral, repair. Okay? Mitral regurg. Okay, so this time, meaning once the ventricle pumps, the blood goes back to the left atrium instead of going to the left, the aorta. Okay? Kasi bumabalik yung may problem with your valves, regurg. Yeah? So hindi nagko-co-update. Pwede makita mo yan sa MVP. It presents with signs and symptoms of CHF. Kasi nga, pag nag-contract yung left ventricle, babalik yung blood to the left atrium, babalik to your backflow to your pulmonary system. The only unique finding is the murmur, which is, yan, pag regurg, guys, pansystolic. Hanapin mo yan. Okay? Or holosystolic. Nakikita mo rin yan sa VSD. Pero pag halimbawa, walang congenital heart disease in patient, tanda lang, after an MI, tas nag-pansystolic murmur, yun, mitral regurg. And usually, it radiates to the axilla. Dalawa lang naman yung may significant radiation pattern. Kapag nag-radiate to the carotids, that's aortic stenosis. Kapag nag-radiate to the axilla, that's mitral regurgitation. Okay? Pag machinery-like murmur, ibang usapan, PDA. Pag in between the scapula, baka aortic dissection. Yun yung mga clue niya. What is your management? Mitral regurgitation, vasodilators. Ayaw mong i-load yung heart with a lot of blood kasi nga nalulunod na siya. Bumabalik yung blood back to the system, pulmonary system. So you have to dilate because you also want to decrease the afterload. Kahit pa paano, pag pump ng left ventricle, hindi masyadong mahirapan to eject the blood out to the system. Okay? At the same time, you decrease the preload with ACE inhibitor or ARBs. So what is the management for mitral regurgitation? Ulit tayo. Actually, guys, hindi replacement yan. You have to do, sorry, hindi ko na-edit to. It should be repair before replacement. Okay. And you have a unique physical findings. Now let's go to aortic regurg. So after relaxation, pump, left ventricle, lumalabas yung blood to the system. Pag relax, boom, dapat hindi bumalik. Dapat mag-close yung aortic valve mo. But it opens because of the aortic regurg. So you have the symptoms. Wide pulse pressure. What is pulse pressure? That's the difference between your systolic and diastolic pressure. Dapat hindi yan lalagpas ng 40, right? Okay? Pag sobrang wide yung pulse pressure nyo, isipin nyo, baka mababa yung ejection fraction or masyadong mataas lang yung compliance. Okay? Because pulse pressure is equal to ejection fraction or stroke volume over your compliance. Okay, so pulse pressure is directly related to your ejection fraction and indirectly related to compliance. Okay, so in patients with atherosclerosis, they are poorly compliant, so they have low compliance, they have a very wide pulse pressure. Okay, so wide pulse pressure in this case is because the systolic blood pressure is high. Okay, the SBP is high because it's able to eject amount of blood, but during diastolic pressure, pag relax niya, babalik yung blood to the left ventricle, sobrang baba ng diastolic mo. So ima-minus mo yan, sobrang wide ng pulse pressure mo. Okay, that's the explanation for your widened pulse pressure. And you have a water hammer, that's the wide bounding pulse. Unique sign, tinatanong to, I don't know, hindi ko alam bakit, pulsations in the nail bed in aortic regurgitation, that's your quincus pulse. Okay, so mga board exam dyan, tinatanong yan. And if you have blood pressure in the legs above 40, above the blood pressure in the arm, usually 10 lang yan. Pag sumobra yan, ibig sabihin sobrang dami ng, sobrang baba ng output mo kasi bumabalik siya. That's what you call the Hill sign. Okay, so quincus pulse, Hill sign. And then sometimes you can see head bobbing, which I haven't seen yet. That's the Dimiset sign. Okay. And the murmur is, of course, during the relaxation, diastolic. If aortic stenosis is crescendo, decrescendo, you see a decrescendo only in aortic regurgitation. And if you ask me, ano yung high pitch, low pitch, prolonged, short, yan. Tingnan mo, regurgitation has a more number of letters than stenosis, right? So yan, mas ano sila, high pitch. Then the stenosis. Stenosis is low pitch. Regurgitation is high pitch. Okay? And they're usually found in the left lower sternal border kasi nga pabalik yung flow from the aorta back to the left ventricle. Kaya doon mo sila maririnig sa baba. Unlike aortic stenosis, palabas, doon mo sila maririnig sa second intercostal space. And the management is just like the same. Most of the management guys decrease afterload, decrease the preload. So careful lang kayo sa diuretic with aortic stenosis. Kasi nga, stenosis siya, di ba? Hindi ka na makapaglabas ng blood tapos bababaan mo pa yung preload mo. So in aortic stenosis, be careful with your diuretics. So in mitral valve prolapse, sinabi ko na to kanina, more commonly found in young women, usually absent yung heart failure symptoms. The common symptoms is a typical chest pain. So if you have a young patient presenting with a typical chest pain, don't right away diagnose with any psychiatric problem unless you rule out any organic problem. They have palpitations and they have panic attacks. So these are the clues that they might be having mitral valve prolapse. So it's worth considering doing echocardiography. Okay, if you are highly suspicious and you hear the murmur. Okay, mid-systolic click. It presents with, that's what I've said, mid-systolic click, that when severe, it is associated with a murmur from MR. That's what I've said, di ba? Minsan hindi sila nagko-cooptate equally. Minsan ang isa, ayan, hindi equal. Kaya kailangan mo i-widen sometimes. So you can have mitral regurgitation, which is a pansystolic murmur radiating to your axilla. Okay. And what are the common medications used in MVP to control symptoms? It's beta blockers because it's more likely related to beta adrenergic activity, like panic attack. That's why they have some circumoral numbness, panic disorder. You have MVP. Beta blocker is the first line. And that's what I have said. If there's recurrent or unexplained stroke, you can start considering aspirin or any anticoagulation in the form of warfarin. And even MVB, endocarditis prophylaxis is not recommended, even in the presence of a murmur of MR. So, kailan ka lang mag-endocarditis prophylaxis with amoxicillin? Okay, may previous history ng endocarditis, or meron kang congenitally unrepaired heart defect or heart transplant patient. Diba? Mga replaced valves, yun na yung kailangan. Magbibigay ka ng mga endocarditis prophylaxis. Now, let's go to cardiomyopathy. Ito, just an abnormality in the function of the heart. Okay? Wala kang ibang cause. There's just problem with the myocardial fibers. You have two types. You have diastolic, or you have dilated cardiomyopathy. Three types pala. You have dilated cardiomyopathy, you have hypertrophic cardiomyopathy. You can also have restrictive cardiomyopathy. So actually, restrictive is just a combination of the extremes of the first two. Dilated is the most common. So manipis yung kanilang wall. Dilated, hindi masyado nagko-contract. Hypertrophic, makapal yung wall nila. So wala silang problem with pump function. Most of the time, infiltrative yung cause. Hemochromatosis, sarcoidosis, amyloidosis. Lahat ng mga dosis. Okay? So that's cardiomyopathy. What are the possible causes? You have this acronym, A, B, C, D. So A stands for alcohol. So alcoholic patients, young patients na present with heart failure. And then when you do the social history, heavy drinker, problems. Letter B stands for beriberi. You have a vitamin B deficiency. Okay, the dry type. And then letter C is Coxsackie B. It's an enteric virus. Letter C, we have three. You have cocaine. You have Chagas disease. Okay, from African trypanosomiasis, American trypanosomiasis. And then you have doxorubicin, which is your anthracyclines that you use in cancer patients. So remember that doxorubicin is dose-related, they are irreversible. So cardiomyopathy is irreversible in the case. There's another drug that is also notorious for causing cardiomyopathy, but they are reversible. Once you remove the medication, nawawala din sila. So yung mga trastuzumab, yung mga HER2/neu receptor antagonist in breast cancer patients. So trastuzumab can also give you reversible cardiomyopathy, unlike doxorubicin. Okay, yan yung Redman syndrome. Yeah, okay. Parang ano lang yan, vancomycin. So the most common cause of hypertrophic cardiomyopathy is actually hypertension. Right? Meron sana akong picture dyan, but it's more likely of HCOM. Kasi magkaiba guys yung hypertrophic cardiomyopathy from hypertrophic obstructive cardiomyopathy. So pag sinabi mo hypertrophic obstructive cardiomyopathy, hindi lang makapal yung septum, nag-o-obstruct pa sila, kaya obstructive sila. Pero most of the time, pag sinabi mo lang hypertrophic cardiomyopathy, makapal lang talaga yung kanilang septum and wall. Okay? They are not obstructing flow of the blood out to the system. Okay? So, for example, you have a vignette. A young athlete, then sudden syncope and death. Yan. Ito yung mga classic cases ng hypertrophic obstructive cardiomyopathy. Okay? Hindi lang HC, HOCM. Okay? Tips, guys. Anything, something that you have to learn from this. Principle. Anything that increases the heart rate will worsen the symptom of HOCM. Okay? The principle here is, I want to dilate my heart chamber size. I want to have it filled with more blood by decreasing the heart rate. Kailangan may enough time para ma-fill yung left ventricle ko, para at least kahit papano, yung obstructing lesion ma-push to the other side, para at least, di ba, mawala, ma-relieve yung obstruction. Yun yung principle. So anything that would increase the heart rate, sobrang bilis ng heart, walang time to fill, hindi siya magdadilate, di walang relief with obstruction, correct? In the same way, anything that would decrease the chamber size would worsen the symptom. So, ang principle lagi is, kailangan ko i-dilate ang size to relieve the obstruction. That's a principle. I want to dilate, I want to increase the size, I want to decrease the heart rate as well. Those are the two principles in treating hypertrophic obstructive cardiomyopathy. So let's see if you can apply these principles. By just knowing the principles, let's see which management is correct or not. Okay. For example, this one. Can you give beta blockers in patients with hypertrophic obstructive cardiomyopathy? Yes or no? So the principle is I want to decrease the heart rate. Why? Because I need more time for the left ventricle to be filled with blood. So beta blockers will decrease the heart rate, correct? And actually that's the medication of choice in patients with HOCM, beta blockers. Why? I want to decrease the heart rate so that more blood will fill the left ventricle. If the left ventricle is filled, then the obstruction can be relieved, right? So if you cannot imagine what I'm saying, you can search in your computer hypertrophic obstructive cardiomyopathy. Makikita mo dyan yung heart mong na sobrang kapal ng septum sa gitna, tas maliit yung chamber size. So pag nilakihan mo yung chamber size, ma-relieve yung obstruction. How about this one? Can you give diuretics in patients with HOCM? What is the principle again? I want to decrease the heart rate. I want to increase the chamber size. So pag nagbigay ako ng diuretics, what will happen to my venous return? Mababa yung blood volume, mababa yung babalik, the amount of blood back to the heart. So malamang, konti lang din ang mag-fill ng left ventricle. Will it dilate my chamber? No, I won't give it. Right? So it will not do any good kasi mababa, hindi madidistend yung chamber size. No, it will not help in increasing the chamber size. So don't give diuretics. You don't even have to memorize. You just have to know what will worsen and what will not worsen the case. Always decrease the heart rate, increase the chamber size. How about giving ACE or ARBs in patients with hypertrophic obstructive cardiomyopathy? What will ACE and ARBs do? It will venodilate, and once ACE and ARBs, and once venodilation is achieved, you also have decreased preload, and decreased preload will not distend the chamber size. That's why you do not give ACE and ARBs as well. Okay, it's more on the preload than the afterload. It has effect both, but it's more on the preload than the afterload. Can you give digoxin in patients with hypertrophic obstructive cardiomyopathy? This is a very controversial question. Why? Because pharmacology, sabi mo, digoxin can decrease the heart rate. O doc, pwede to. Kasi bibigay mo to. Kasi I want to decrease the heart rate para more time with filling. But at the same time, you know that this is a positive inotropic drug. It means it can squeeze my heart stronger than the rest of the medications that we have mentioned. So anong pipiliin mo? Decreased heart rate or decreased cavity? So actually, it's more of a positive inotropic effect than a negative chronotropic effect. So if I were to answer this question, I would not give any digoxin. Why? Because even if it slows the heart rate, sabihin natin 55 yung kanyang rate per minute. 55, 1, 2, but each time the heart pumps, the inotropic effect is achieved. So each time it pumps, the left ventricle cavity size is very small. So madidefeat mo rin yung decreased heart rate with a decrease in the chamber cavity size. So do not give this. Okay. Can you give hydralazine in patients with hypertrophic obstructive cardiomyopathy? Ang alam ko, hydralazine can decrease after load. Well, what will it do? The principle here, guys, is you have to increase the afterload, okay, to relieve the obstruction. Okay, so once the afterload is increased, it will push the blood back to the system, and it will somehow relieve the obstruction. So hydralazine can worsen the symptom as well by decreasing the chamber size. Okay, because it will decrease the afterload and it will not relieve the obstruction. The differential pressure is also decreased. Okay, I hope you understand that principle for HOCM, decrease the heart rate and decrease the chamber size. Yun lang kailangan isipin. Then I hope you have the knowledge of pharmacology, the effect of preload and afterload physiology with how you reconcile things. So this is classic once you do an echocardiography, once you see SAM of the mitral valve, that's diagnostic for hypertrophic cardiomyopathy. The systolic anterior motion of the mitral valve. Okay? And remember this, diuretics may help in hypertrophic cardiomyopathy, but they are contraindicated in hypertrophic obstructive cardiomyopathy, as what I have said, because it will decrease the preload, it can worsen the symptom. Let's see if you can answer this one correctly. In hypertrophic cardiomyopathy, will you give beta blockers? Yes. How about dilated? Para ka lang nagtitreat ng heart failure in dilated cardiomyopathy. Of course, yes. Okay. Will you give this in hypertrophic obstructive? Yes, that's even the medication drug of choice. Okay, diuretics, can you give it in hypertrophic? Yes. Can you give it dilated? Yes, but I cannot give it in obstructive hypertrophic cardiomyopathy. Okay. ACE inhibitors or ARBs, no evidence in hypertrophic cardiomyopathy. Dilated, you can give it, just like you're treating heart failure patients. I cannot give it in hypertrophic obstructive kasi nga bababa yung preload nila. Chamber-sized cavity will also decrease. Can you give spironolactone hypertrophic? No benefit. In dilated, yes, especially in heart failure with NIHA 3 and 4 symptoms. You're just treating heart failure again. I cannot give it in hypertrophic obstructive cardiomyopathy. Okay. Digoxin, do not give it in hypertrophic, no benefit. Only in dilated heart failure, and of course, you cannot give it in HCOM. So basically, guys, if you look at it, only beta blocker is beneficial for HOCM. Okay. In dilated cardiomyopathy, you're just like treating heart failure if you're looking at it. And hypertrophic cardiomyopathy, as what I have said, beta blockers lang at diuretics. Para kang nagtitreat ng heart failure with preserved ejection fraction. Kasi nga hypertrophic siya, it can pump enough blood out of the system. I hope that makes sense. Okay, as what I have said, a combination of the worst aspects of dilated and hypertrophic, that's yours, restrictive cardiomyopathy. Sarcoidosis, amyloidosis, you have an apple like birefringence, right, in your staining. Hemochromatosis, and daming ferritin level too high. Scleroderma, you can have endomyocardial fibrosis. Those are classic of your restrictive cardiomyopathy. And even sarcoidosis, yeah, you can have it. But unfortunately, sarcoidosis is patchy. So sometimes kahit mag-biopsy ka, hindi mo makatch kasi nga hindi siya diffuse. Unlike the amyloidosis na diffuse siya. So kahit saan ka mag-bite, makikita mo talaga yung fibrotic changes. So in sarcoidosis, iba. So minsan patchy siya, so hindi mo siya makatch. Kaya mahirap pag-diagnose ng sarcoidosis in the heart. And the true accurate test for myocarditis in the heart is biopsy. So viral myocarditis is the most common cause, right? Enteric viruses. COVID actually can give you myocarditis as well because the heart has ACE2 receptors. Yeah. Lately, flu, also influenza, notorious in giving you myocarditis. Giant cell myocarditis is also there. If you see giant cells in pathology, yeah, caused by viral infection, inclusion bodies, yeah, etc. So here we have pericarditis. So inflammation of so cavities surrounding the heart. The EKG shows, we have already said this, the ST elevation in all leads, and the morphology is concave, not convex. And the most specific sign is your PR segment, depression in all leads apart from the AVR. So AVR has PR segment elevation. The rest has PR segment depression. You don't have any Q waves there, unlike in STEMI. And in STEMI, you don't have any PR depression, okay? And then in STEMI, the morphology of the elevation is convex. Yun yung clue mo dun. Kasi minsan, they both have troponin, especially pag may myopericarditis, minsan may troponin leak din. So you have increased troponins, and then you have ST elevation. And it looks like, oh, this is STEMI. Yun, treat ka agad, aspirin, and dual antiplatelet. Tapos isipin mo, pag nag-aspirin ka or nag-NSAIDs ka, what if this patient has hemorrhagic pericarditis, di ba? So, nag-worsen ka pa ng case. Kaya kailangan mo ma-differentiate pericarditis versus the myocardial infarction. Kasi sobrang different na kanilang management, right? Bibigay ka lang ng NSAID and colchicine for pericarditis. And if not, you do pericardiectomy or pericardiocentesis if ever my significant fluids or pericardial effusion or cardiac tamponade. Okay, and the most, yeah. So yeah, and colchicine decreases the recurrence of pericarditis. So always treat first pharmacologically. Pag meron kang case ng pericarditis, what will you do first? So give NSAIDs plus colchicine before you do any aggressive management. Okay? So what if you have a patient history of lung cancer with sudden shortness of breath, with hypotension, with sinus tachycardia, with jugular venous distension, but clear lungs? Ayan. So baka naki-hemorrhagic yan, effusion, okay? And clear lungs ka, ibig sabihin, the ventricles are not pumping enough blood to cause an edema. Okay, you have a JVD, it means the heart is loaded with a lot of blood, and you have hypotension. That's a case of pericardial tamponade. What is the Beck's triad? Do you know? So it's hypotension with jugular vein distension with muffled heart sounds, right? So if you have those three, likely the patient is pericardial tamponade. And what is this sign? This is your pulsus paradoxus, right? The decrease in blood pressure on inhalation is more than 10. What are the signs in EKG that you see in pericardial tamponade? Since the heart is swinging, kasi nga may fluid around, okay? So hindi siya makapump ng maayos, hindi makatransmit dun sa EKG leads mo. So you have an electric alternance. So titingnan mo yung QRS, mataas, mababa, mataas, mababa, mataas, mababa. So that's it signifies a swinging heart in the around in the midst of a fluid. Parang ganun yung picture. And you have an X-ray of a globular heart, minsan water bottle sign, nakita mo yan. And an echo, very specific pag nakita mo yung diastolic collapse. So, di ba isipin mo, pag once nag-diastole, the heart should relax, right? In diastole, it should expand. But in pericardial tamponade, it will collapse. Kasi nga, there is pressure around it. Okay? And then the right heart cath, once you have a Swan-Ganz catheter, you have equalization of pressure in the diastole. So remember, the right atrium is like 0 to 5 mmHg. Okay, and then the right ventricle usually has like 20 mmHg. So once you have an equalization of pressure between the right atrium and the right ventricle, it means that there is a pressure surrounding it that would equalize those pressure inside, intra-chamber pressure. So once you see equalization of pressure, think about tamponade. Okay, and that is very dangerous. So you have to withdraw the fluid. You can do pericardiocentesis, and if it's like hemorrhagic or if it's like malignancy related, pericardiectomy is even warranted. Okay? Kailangan tanggalin mo yung pericardium para hindi mag-recur. Okay? Sabi na natin yan. And constrictive pericarditis most likely associated with a cosmal sign. So cosmal sign is what I have said. The JVD is increased on inhalation. So normally dapat mababa yan since the pressure is lower in the heart during inhalation. But because but if there's constriction around the pericardium, then you have that. And then another clue, you hear the pericardial knock. Ayan, sureball. You have a constrictive pericarditis. Okay? It could be from tuberculosis. It can be from connective tissue disease. Pwedeng galing yan sa SLE or chronic TB. Ganun. Yun yung mga case. Or maybe radiation, history of radiation prior. Nagkaroon ng fibrosis around the pericardium. And the best initial test is like a chest x-ray. You see calcification. So pag nakita mo yung calcified pericardial area with pleural effusion, yan, sureball ka meron ng constrictive pericarditis. But if they ask about the most accurate test, CT MRI. Yeah? CT of the scan of the chest, MRI of the chest. And the management is diuretic. You have to decrease preload and removal of the pericardium in case of chronic TB and malignancy related or connective tissue disease. So you have a case, a diabetes with smoker and leg pain in the calves and exertion. What do you call this symptom? Walking up and down the hills relieved by rest. Okay, you call it intermittent claudication, right? That's classic for peripheral artery occlusive disease or PAD or PAOD. Okay, and the best initial test you can do in the clinic when they ask you, it's your ABI, right? Your ankle brachial index. Get the blood pressure from your legs dorsalis pedis or posterior tibialis, depende sa'yo. Then do a brachial blood pressure, compare them, okay? Divide ankle versus the brachial index. Ideally, di ba, kung isipin mo, dapat mas mataas yung pressure in the legs than in the arms kasi nga by gravity. But if it's less than 0.9, that's a number. If it's less than 0.9, less than 90% ang ankle blood pressure mo sa brachial, then you can think of an artery occlusive disease. However, this is a clue. If you have a ratio of more than 1.4, feeling mo, wow, perfect kasi 1.4, taas-taas. That's abnormally high, too high. It means that the vessel in the lower extremities are calcified, too calcified. And the ABI is not reliable anymore. So once you see an ABI of 1.4 and above, okay, you proceed with a toe brachial index. Okay, that's more reliable in calcified plaques or calcified vessels in the lower extremities. So 0.9, PEOD significant. What you do, the most beneficial management is supervised exercise regimen. That's your answer to your exam. Okay. Medication, the only medication that gives benefit is the lostazole. And since it is an arterial disease, aspirin and also statins can benefit the patient. Right? The most accurate test, of course, is angiogram. You have to see, like vessel, if they want to do any bypass, grafting. What I've said, the single most effective medication is your PDE3 inhibitor. That is your cilostazole. It will increase your CAMP and then inhibit your platelet aggregation, homogeneous vasodilatation. But if they will ask you what is the most effective management in PEOD, it's not cilostazole, it's supervised exercise program. It's different from a home exercise program that the doctor can actually instruct the patient, no? It's actually a supervised program. Nakikita sila ng doctor, ng therapist, tina-time sila, then they have tolerance, pain, all those stuff. So that's the most evidence. The most beneficial intervention for PEOD. Okay. Try to answer this question. A 67-year-old man comes to the ER with sudden onset of chest pain, and he also has pain between his scapula. This is your clue. He has a history of hypertension and tobacco smoking, and his blood pressure is 169/108. What is the best initial test? Of course, I will not do CT angiogram. That's too invasive. I will not also TEE and letter D. That's too invasive as well. Of course, pipili ka na lang ng TTA, angiography, pareho sila angiography. Between chest X-ray and chest CT, what will you do? Guys, ang question is initial test. Okay, hindi most appropriate, hindi most accurate, but initial test. So by the looks of it, I am thinking that this patient can have aortic dissection. This is the clue. Pain between the scapula. Radiating pain, ripping pain, tearing pain, radiating to the back, in between the scapula, and you have a hypertension. Usually, it will give you an unequal blood pressure in the upper extremities. Differential blood pressure. Like sa kabila, like difference of more than 20 and the other side. 180 sa kabila, 160 sa kabila. Yun yung clue mo na this is an aortic dissection case. Okay, so the initial test that you do is the chest X-ray, right? What do you see in the chest X-ray? You see mediastinal widening. Yun yung first clue mo. Boom, baka nag-aortic dissect na to. Okay, so yes. However, the same patient, and then they ask you what is the most accurate test, not what is the initial test that you do, but the most accurate is actually your MRA, magnetic resonance angiography. Okay, so in this case, guys, you have to understand basic principles in aortic dissection. So there are two types by Stanford, type A and type B. Ang type A, the source of the tear in the intima is located in the proximal aorta, ascending aorta. Okay, once it is in the descending aorta, that's a type B. Most of the time in type A aortic dissection, that is surgical intervention. So type A, pag nasa proximal ascending aorta yung tear, call surgery. Okay, that's the only time you consult surgery right away. But if it's type B, okay, type B aortic dissection, medical therapy is sufficient. And when giving when giving medications for these patients, you always have to start with a beta blocker. Don't start with any nitroprusside, because we have learned right a while ago that the drug of choice for hypertensive emergency is nitroprusside, because it has both venous dilation effect and arterial dilation effect. However, in these patients, you don't want to drop the blood pressure right away and cause reflex tachycardia, right? Because our goal is to decrease the shearing force on the vascular, on the vessel. So, kung nagbigay ka ng nitroprusside, yay, goal is less than 120 within the first hour. Why? There are only three cases. There are only three cases in hypertensive emergency that you want to decrease the blood pressure after an hour. Okay? Only three cases. First is pheochromocytoma. Second is severe preeclampsia or eclampsia. And the third is aortic dissection. Among these three cases, you have to drop the blood pressure to less than 140 in 1 hour for pheochromocytoma and severe preeclampsia. You can drop the blood pressure for aortic dissection to less than 120. That's the latest guideline from the American College of Cardiology. Less than 120 within the first hour, okay, for aortic dissection, because you want to decrease the shearing force. However, do not use nitroprusside for reflex because of the concern for reflex tachycardia. Use beta blockers. So you can use labetalol, esmolol, or drips. So always start with the beta blockers in aortic dissection, because apart from decreasing the blood pressure, you also prevent reflex tachycardia. Okay, so that's hypertensive emergency. Hypertensive emergency is defined as one blood pressure of 180 over 110 and or plus an organ damage, right? Hypertensive urgency, mataas ang blood pressure without any evidence of an organ damage. Okay, look for papilledema as a sign of organ damage. Look for AKI, look for chest pain, look for flash pulmonary edema. Kung meron kang ganon, that is hypertensive emergency. And if the cause is pheochromocytoma, if the cause is severe preeclampsia and aortic dissection, immediately reduce the blood pressure to less than 140 and 120 for aortic dissection in the first hour. However, kung wala sa tatlo ang cause, you can decrease the blood pressure only to 180 in the first hour, and the next 6 hours to less than 160, not more than 25% of the MAP. So compute the mean arterial pressure, don't decrease it to more than 25%, or even calculate the 25% of the systolic blood pressure. You can normalize the blood pressure within the next 24 to 48 hours. Kung wala sa tatlo yung kaso. Okay? Ibang usapan yung ischemic acute onset ng stroke. Ibang usapan yung hemorrhagic stroke. Okay? You can also decrease the blood pressure, but not too low. Okay? Because you don't want also to induce another stroke, ischemia. So 20 to 25% of the systolic blood pressure or MAP is the goal. How about screening for aortic aneurysm? Ito guys, mahirap itong alalahanin. Pero in aortic aneurysm, any aneurysm, from the ascending aorta down to the thoracic aorta, I only want you to remember three numbers for the purposes of the exam. 5.5 cm, 0.5 cm per year, and 4.5 cm. So what do I mean? The only indication for repair in any size of the aneurysm is 5.5. Pag nakita mo yung 5.5 cm, kahit saan pa yan, aortic aneurysm ba yan, descending aortic aneurysm, abdominal aortic aneurysm. If it's 5.5, the answer is surgical repair. Unless the patient has Marfan syndrome or Ehlers-Danlos syndrome, then the threshold is lower to 4.5. The rest of the people, 5.5 is the threshold. And or there is expansion of more than 0.5 cm per year. Okay? So three numbers. 5.5, 0.5 cm per year expansion. So, halimbawa, sinabi nila 5.4 cm. Pero after 6 months, nag-6 na siya. So that's a 1 cm in 6 months. That's more than 0.5 in a year. So surgical intervention is warranted. Okay? And or there's persistent symptoms like back pain, all of those stuff, like decreased blood pressure. Okay, So, but by virtue of sizes, yun, 5.5, 4.5 for Marfan syndrome or Ehlers-Danlos. Those are congenital disease in your elasticity, elastin, fibrillin, all those stuff. So lower ang kanilang threshold kasi mas at risk sila for aortic dissection congenitally. Okay? And a surgical repair for type A dissection, that's in the proximal aorta before the last branch. Tingnan mo, nakalimutan ko lang. Last branch ng DCS aorta mo. So you have vertebral artery, you have common carotid artery, and subclavian. So after the subclavian artery mo, that's already type. Actually, after the aortic arch, that's type B already. And the aortic arch is up until the subclavian artery. Okay, so below the subclavian artery, that's a type B Stanford classification. Management is medical therapy unless there is malperfusion, unless there is persistent symptoms. Okay, but commonly, medical therapy lang pag type B. Pag type A, no question, surgical repair agad. Type B, medical therapy unless there are signs of malperfusion, AKI, then you have rapidly expanding aortic aneurysm, persistent symptoms, then that's the time you can call surgery. Okay? And as far as the types of surgical intervention is concerned, ito lang isipin mo, pag AAA na, abdominal aortic aneurysm, know where the location of the aneurysm is. If it's suprarenal or juxtarenal, malapit sa renal artery, then you do an open repair. Okay, pag infrarenal, then you can do an endovascular repair or open repair. It depends on the comorbidities. Okay, I don't think they will ask it, but in surgery, baka tanungin kayo. Okay, so juxta or suprarenal aneurysm, open repair, open surgical repair. Infrarenal, you can do endovascular repair. As far as screening is concerned for aortic aneurysm, guys, only the smoker, only men above 65 are qualified for aortic aneurysm surveillance with an echocardiography. The rest, hindi na sila indicated. Okay? Babae, hindi sila even indicated. Even smoker pa sila. So only men, whoever smoke, above 65 with ultrasound. That's the most appropriate screening for aortic aneurysm. And most dangerous for pregnant women is peripartum cardiomyopathy. It is reversible after pregnancy, but sometimes they are recurrence because repeat pregnancy will provoke antibody production. They look like dilated cardiomyopathy and autoimmune. And if LV function does not improve after delivering the baby, cardiac transplantation is even the treatment of choice. But if there's no peripartum cardiomyopathy, then the answer is letter C, Eisenmenger phenomenon. It's like reversal of your left to right shunt, right to left shunting. Okay. So I guess that's pretty much it for cardiology, and I don't think I have enough time for infectious disease. So right now, you can ask some questions if you have. I cannot finish everything. I still have infectious. I still have POM. I still have endo, but I think I can just give out the slides to you guys. I hope you learned something. If you have questions, you can actually type them or you can start asking. Kaya baka mahirapan tayo kasi ang dami nga. So, yeah. Oh, there's a murmur. There's a question. In the next break, could you explain how, again, the intensity of the murmur decreased in patients with HOCM during increasing is determined rivers like squatting? Thank you. Okay, so as what I have said, in HOCM patients, we have to increase the left, the left chamber diameter to distend or to push the septum, the enlarged septum, para ma-relieve mo yung obstruction to decrease the murmur, to decrease the differential pressure between left ventricle and the aorta outside. Okay? So once na-relieve mo yung obstruction na yun, meaning the pressure in the left ventricle and the pressure in the aorta is almost the same. So wala ka masyadong differential pressure, so wala ka masyadong pressure gradient, wala ka masyadong murmur. So you can achieve that by putting more blood to the left ventricle, by doing squatting and leg raising. So increasing the venous return will decrease the intensity of HCOM by increasing the left ventricular chamber size, distending the obstruction or relieving the obstruction and equalizing the pressure, almost reducing or eliminating the pressure gradient. Does that make sense? Okay, just curious about the mechanism of colchicine with decreased recurrence of pericarditis. Actually, colchicine has many effects. It could it has a role with neutrophil migration, and pericarditis has what's this role? I mean, inflammatory is an inflammatory condition, so colchicine can help you with that as far as inflammation is concerned. And also right now, it can even, there is an ongoing research. We are actually doing it about the effect of colchicine in CAD as well, and ACS. So it's still ongoing because there are certain receptors in the human, I forgot the name of the receptor that is very receptive to, I mean, the receptors are very sensitive to colchicine, that they have low, I mean, contractility effect, more effect on contractility once that receptor is stimulated, but it's more on the heart failure ACS system. But as far as this question is concerned, pericarditis anti-inflammatory, so neutrophil migration, yeah, that's the main pathway why colchicine would decrease recurrence of pericarditis. Does hand gripping affect venous return? Unfortunately not. Hand gripping is more on the afterload. So that's why, unless you squat at the same time, because hand grip is more on more on the arteries perfusing that area. So brachial arteries, subclavian artery, more on the afterload than, because the veins are not too large in those areas to cause decreased venous return. So unless you grip at the same time you squat, then that could affect your venous return. But if only hand gripping is a question, then it's more on the afterload than the venous return. I hope that's clear. You're welcome, Jason. Yeah, you're right. So it pushes the obstruction away of HOCM. You are perfectly correct. So you distend the obstruction, you decrease the pressure gradient, you decrease the intensity of the murmur in HOCM. Any other questions? I cannot answer all your questions. I do not know a lot. Why specifically is beta blocker used for dissection? So first, it will decrease the blood pressure by decreasing the heart rate. And remember, blood pressure is the product of your peripheral vascular resistance times your cardiac output, and cardiac output is stroke volume times heart rate. So once you decrease the heart rate, you decrease the cardiac output, at the same time decreasing the blood pressure. Plus, you have a component of decreasing reflex tachycardia. So it has a benefit to counteract reflex tachycardia, and also reflex tachycardia, and then the blood pressure reduction. So both of these will benefit your patients with the aortic dissection. Decrease shearing force at the same time, and then blood pressure reduction. Yeah. I hope that makes sense. Any other questions? I hope we get another section for ideas. Let's see. Yeah. I'll just let you know, guys. If I'm still on a break this week before I go to the ICU, so I can probably spare some time. No promises, but I'll do my best. Of course, it's my passion to teach and make you competent doctors. It's just that I'm busy with a lot of researches. We have pending publications for COVID and AKI and different journals. So, but I'll do my best. I'll do my best to share what I know. Sure, Daniel. You're welcome. Renal, yeah, I also have renal slides. Actually, I made this for the 2019-18 batch. I have IM, I have surgery, I have OB, I have pedia. I can give all the slides though if you want. Yeah, most of these slides come from my USMLE references. I've been reviewing different basic sciences as well, anatomy, pathology, pharmacology. meron akong slides lahat, so I can share them with everyone. I just hope I have enough time and I have, wait lang, may nagmu-music eh. The squatting or leg raising correct the pull-ups, barbs, and MVP. Actually, the mechanism is not very specific, but theoretically, once you increase the venous return back to the left, right atrium, right ventricle, and then the left side of the heart, you can somehow distend the mitral commissure. And in mitral valve prolapse, sometimes they coaptate unequally and they do not coaptate the valve at the same time. So you do it this way. You have a leak in between. So once you distend it, sometimes you equalize them at the same level, and you can reduce the differential pressure between the left atrium and the left ventricle amount of blood. Theoretically, yeah, that's how it decreases the murmur. Yeah, that's what I've said. So OCM and MVP, these are the two unique valvular diseases that are indirectly proportional to the mechanism. Decrease preload, decrease afterload, increase murmur, and the other way around. Just for the two of them. The rest of the murmurs actually go the same way. Increase preload, increase murmur, increase afterload, increase murmur, except for the two. You all right? Any other questions? You're not sleepy, guys? Good for you. I am not sleepy though because it's morning here. It's 10 a.m. and we're traveling to West Virginia just for Jollibee, 3 hours. My wife is craving for that. I don't know.
Aray.
New Jersey is like 2 hours from here, but there are a lot of cases in COVID, so we'd rather go to Virginia. I'm not driving though. Maybe pabalik. Papunta doon, andito naman kami sa cousin ko. So siya mag-drive. Kasi pagod ako. Yung buntis nag-crave. You're welcome, Cam. My pleasure. I hope you understand something, even just like one bit, one piece, one technique in answering questions. That's good for me. I mean, salamat. Yeah, I'll do my best to schedule for another session. I'll just let you know when is the next possible time. Maybe this week. For sure, maybe this week. Kasi wala pang ginagawa. As long as di pa bigyan ng research load. You're welcome. You're welcome. You're welcome.